Hello, everybody. Thank you for being here right on time at 9 a.m. for the training. I'll just give folks a couple seconds to hop on before we get started. We do have a good number of people signed up, so I'm excited to have you all here with us today. All right. Since we do have a robust presentation today, I will go ahead and get started. So, welcome. My name is Alejandra Del Toro, and I am the Education and Community Coordinator with Empower Idaho. I wanted to start out by sharing that we have questions and tech assistance available for you. So if you would like to write down these email addresses, myself and my colleague Anna Guida are available if you're having any issues. So Empower Idaho. So for those of you who aren't familiar, Empower Idaho is a nonprofit organization that is funded by the Department of Health and Welfare, Division of Behavioral Health, and we offer education and advocacy in the community for adults with behavioral health conditions in Idaho. This includes educational opportunities for behavioral health providers, which most of you that are here fall under that category. So quick control panel overview. If you are unfamiliar with GoToWebinar, everybody that is in the audience is muted, as well as having the webcam option turned off. So the way that you would communicate with us is through the questions drop-down box. So if you can take a look at your control panel, look for that questions drop-down. I recognize that it's titled questions, but it's not only for questions. If you have any comments, please do feel free to use that option to write down your thoughts throughout. I will note that because, again, we do have a very robust presentation today, we will be answering questions at the end. However, we do highly encourage you to put those questions in the chat box as they come up. So we have a list to review at the end there. I'm sure many of you are here for CEUs, and so just a reminder, all of the CEU information as far as what makes you eligible for those 4 CEUs can be found in those reminder emails that were sent to you. So if you could reference those so you can make sure that you are adhering to all of our guidelines, all of our rules in order for you to be eligible for that. Again, all of that information is included in the reminder emails that you received. All right, and as you see here, we have our wonderful presenter, Dr. Ryan Melton, here with us today, presenting cognitive behavioral health therapy for psychosis. So I'll go ahead and turn it over to you, Dr. Melton. Thank you so much.
Yeah, happy to be here. I appreciate seeing the large number of participants. I figured everybody would be eagerly weaning the outcome of the herd death trial, and there'd be like 6 people on the line. So I really appreciate those that are here. I guess when the verdict is announced, if I see a bunch of people logging off, I won't blame you for that. I mean, other than that, do appreciate you being here. This is somewhat of a robust training, although it is a pared down training, won't have some of the specifics that I normally would like to do given the short time frame. Happy to make myself available to go into more specifics on cognitive behavioral therapy and how it works specifically for psychosis. Some little background about me: I am the Dean of Psychology and Counseling at Bushnell University, certified in training cognitive behavioral therapy with psychosis at the Fidelity level. Been involved with early schizophrenia, early psychosis work for the last 20 years, wrote the Fidelity guidelines for the early psychosis program in Oregon and consult with early psychosis programs around the country, doing both cognitive behavioral therapy as well as differential diagnosis. I'm trained on some of the instruments to diagnose early psychosis and the such. So that's a little bit about me, and just to give you some background on who I am and why I'm somewhat qualified to train this topic. But let's talk about some of the learning objectives. Today, we'll learn the phases of CBTp, that's cognitive behavioral therapy with psychosis, learn some skill sets applicable to each stage. I have included in your packets, which I hope you all received, a handful of instruments, handouts that you can use to work with your clients. I generally get feedback on trainings like this that people really want techniques. I'm somewhat hesitant to do that because cognitive behavioral therapy is so much more than just the techniques. I refer to that as CBT-like practice, where I really want to do CBT fidelity-based practice. That being said, I'm happy for you all to do some CBT-informed or CBT-like practice where you're using some of the handouts that I provided for you. And we probably won't get a lot of chance to practice today. Just kind of given the timeline, I do practice is part of CBT. Home practice for your clients is important, as well as practice for you. We'll go through the training in essentially 5 parts. See what we get through. We'll talk about some of the CBT fundamentals and just the structure of the theory or of the practice. Talk about engagement, assessment, go to engagement, then assessment, hit some interventions, and then if time allots, hit some relapse prevention.
Hey, this is Alejandra again. I just wanted to quickly note that everyone received those handouts this morning via email. So check your email for that.
All right. So I gave this academic introduction to myself, which some people have told me that involves some level of intimidation, probably not with you all, but with my students for sure. Many of my students don't even want to take some of my courses because they're worried about the Melton intimidation factor, as they call it around the university. So I like to start off with a little bit of cognitive restructuring just from the beginning and do a little bit of cognitive re-imaging in some ways. So I also will introduce myself as somewhat of a cosplay aficionado, especially around the Marvel areas. I do like to get involved with that. I do consider myself now a cool nerd. I wish comics and everything else would have been as cool as it was when I was in middle school, as it is now, and maybe I would have been much more popular. But that's really who I am. My family and I like to dress up, particularly around the Halloween area or during Marvel events, to just show our fanfare. I show this image to my students because it's a cognitive restructuring technique or re-imaging techniques. Instead of having this idea of this intimidating professor that's done all this work in early psychosis and research and blah, 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 I'm also a dude that puts on, shaves my beard, puts some white in my hair, although I don't have to do as much as I used to, puts on a cape and can have a little fun also, with the idea of just kind of activating their parasympathetic system so they're not so intimidating when I walk into the room. And it's true, it's my university. My family laughs at this, but at the university, I am somewhat intimidating. So I like to re-image that. This is also something you do. This is a technique in cognitive behavioral therapy with psychosis too. Many clients will describe distressing voices that tell them to harm themselves, voices that tell them to do something that they're not comfortable with. And I will sometimes have them draw or talk about what that image looks like. And then we may shift. I said, what if your image looks like this? And I'll show a picture of a puppy, or I'll show a picture of a baby, or I'll show a cartoon character. And it's going to get them laughing and rethinking about that image. They may actually have some control over what that image is. So there, you got your first CBTp technique. Yeah, so learning is continuous. If you just go to a training and you walk away from it, you're not going to take a ton of information. If you want to get involved with this, I would strongly encourage you to get involved in the didactic work, role plays, some case-based presentations. I currently offer a monthly consultation on CBTp. If that's something you're interested in, we can talk about that. And obviously some internal supervision, consultation, just some ongoing learning. Otherwise, it simply fleets away. These are puppies. Another technique that I like to put into my trainings, as well as sometimes even in my therapy approaches, is to just have a calming image as people's anxiety starts rising about the work that's going to be involved. I'll throw some pictures up of puppies or kittens or maybe my children, up on the screen, just to give a image of calm. Again, the whole idea is to reactivate the parasympathetic system. Research has shown that when you do give people a large amount of intensive information, it's nice to pair that or match that with more calming images, helps them kind of be grounded and take the material in. So something I do in classes, something I do in therapy, just to keep the flow going and to kind of keep people on their toes. Just some training tips in terms of retention. This is important both for training, but as well as for therapy. Okay, I think it cross-pollinates in that way. Of retention, people will remember about 10% of what they read, 20% of what they hear, 30% of what they see, 50% of what they see and hear and see, 70% say and write, and then 90% of what they do with, usually in the form of an activity. Now, this type of study, or this study, was done with quote unquote a broad-based population. So anybody, this is probably true for all of you in the audience, true for me, true for the general population. But if we think of schizophrenia is a cognitive disorder at the heart of the condition, meaning that the cognition is impaired. One of the primary areas of cognition that seems to be impaired in schizophrenia or individuals with psychosis is working memory. So this idea, working memory in short, is our memory process that takes in information, moves salient or important information into our working memory, which ultimately can help retain it and move into long-term memory. Now, that's not everything we hear. Again, that's only about 20% of what we hear. Now you take schizophrenia, we could probably cut that in half. So when treating individuals with psychosis and schizophrenia, it's essential that you are using worksheets, that you are writing things down. I say the top tool in working with individuals with psychosis, schizophrenia is a whiteboard. So where you're writing down the lessons, you have the agenda, you're drawing out the cognitive triangle, you're working through those with a visual aid, and then you have the client's practice. Otherwise, much like a training where if you just hear it, you're not going to retain that much. The same thing is true with individuals in treatment. We just talk at them, they're not going to retain a whole lot. And cognitive behavioral therapy is really seen as more of a psychoeducational theory technique, where we do want people to learn skills which they then replicate and ultimately take on. So we really are trying in a lot of ways to really activate the executive functioning, which is an area of the brain that seems to be has challenges when it comes to schizophrenia. Now, just be honest when it comes to, if I were to say, hey, one thing that we're going to do is I'm going to put a couple of you and we're going to do some role plays. We're going to role play CBT. I said that, what kind of thoughts come into your head? And I'll just give you, this will probably be the only major active portion. If you could just type in the chat, hopefully I can see it, just a couple of thoughts that come to your head when I say, we'll call people randomly from the audience and we'll watch them role play cognitive behavioral therapy. Could you put what thoughts come to your head?
Perfect. And it looks like some of those are coming in. Dr. Melton,
Okay.
if you're able to see them.
I am seeing them now. Yeah, yes. I'm not good
Awesome.
enough. This is anxiety provoking. I don't want to be embarrassed. Nervousness. Yes, you can wear a cape. I like that. I just graduated. I'm not dressed yet. That's awesome. I hate role plays. Maybe helpful. Behavior change nightmare. All sorts of weakness defined. Okay, don't get anxious. All right. Also, it seems fake. Yeah, I've heard that with role plays before. Okay. Good. All right. Am I competent for a role play? Yeah. Okay. How do I close this now? That's my. Am I competent enough to know how to use?
Is it getting all up in you, the questions?
Yeah.
Full on in your screen? You should be able to click that arrow at the top right to have it go away.
Oh, okay. All right. Thanks.
Yeah, of course.
Part of it went away. The questions didn't go away, but maybe I can turn that off. Okay. How do I close this? Performance anxiety. Some really good comments here. Yep. I don't know how to close this. I'll just do that. All right. Okay. Well, thank you for that. I think a good portion of the comments were of fear and anxiety, embarrassment. I'm just a student. A lot of those type of comments. In cognitive behavioral therapy, we call those automatic thoughts. We call those the thoughts that appear right when a stressor or event is present. Those thoughts that just come to mind automatically when something is presented to you. So me saying, all right, what we're going to do right now is I'm going to call on a couple of people and you're just going to act out what you know about cognitive behavioral therapy and go. So the automatic thoughts, again, majority of the comments, nervousness, fear, this is fake, useless, those type of thoughts. So it gives me some ideas right away what type of thoughts you all are having. CBT, as probably most of you are aware, in a lot of cases is trying to target those automatic thoughts. We target them in different ways, but essentially as we try to target automatic thoughts, change them to reduce anxiety, depression, psychosis, and a wide range of symptoms. Sometimes images pop up too. So I think there was comments about being embarrassed. And so sometimes it's not even words or thoughts that come into your heads, but images, people laughing at you, people pointing at you, people mocking you in those type of ways. That also happens with individuals and happens quite often with individuals with psychosis, where it's not thoughts necessarily, but images. Sometimes those images come out in visual hallucinations or visual distortions. So we're also targeting that as well when anxiety is provoked. Good news is I'm not going to make you do role plays. Now, if you were with me live, we might do a couple of role plays, but given the nature of this training, you're free, no role plays today. So I won't be pointing at you. Your colleagues won't be pointing at you and making fun of you, which, to be completely honest, I do not believe what would happen. In fact, one of my target treatments would be to modify your thoughts or modify the images to something like, although it could be anxiety provoking, it's important for my learning. I mean, I am a new student. There really isn't a high expectation for me, but it's good for me to show my colleagues that I'm willing to get up there and understand this. I think someone did say it could be fun. That's great. That's a different automatic thought that that if you weren't at that place, we'd want to get you. It could be fun. It may cause a little bit of anxiety, but it may be fun. And in CBT, it's not binary though. It's not, this is all going to be okay or not okay. We do a lot of ranking and we acknowledge that many events do provoke anxiety. Many of events do provoke thoughts of depression. A lot of our work is to reduce that. So we see it all on a spectrum. So reduce the intensity of the symptom when faced with a stressful event and maybe do something about it which allows for ongoing functioning so that the symptom, whether it be voices, depression, anxiety, doesn't stop the individual's functioning. In no way does CBT say that all of this has to go away, that you have zero anxiety. That's not the goal. The goal is to get your anxiety, your psychosis, your depression to a point where you can continue to function, or the individual can continue to function. So really, when we think about role plays, you know, before I even did a role play, and you'd want to do this with clients too, because there is a lot of practice. We want to try to change the thinking right up front. You wouldn't want to throw somebody right into a role play. You wouldn't want to throw a client right into practice. You want to be able to clear to say that what we're going to do is to help you learn new skills, improve on skills, teach skills, and to really get the most out of trainings, or the most out of the work that you're doing. In no way is it to de-skill anyone or produce high levels of discomfort. I would say it's there to produce enough anxiety where you can feel like there's going to be improvement, but it's certainly not here to embarrass you. And if I would have done that and really set up this idea on role plays in that way, not saying people's anxiety would have gone away, I would hope that it would have been a little bit less and you would have felt a little bit more comfortable about doing it. So setting the stage, so to speak, is absolutely key in CBT work. Yeah, so again, I did say the previous one was the last chat, but I do want to just hear a little bit about what your concerns are about administering CBT, so I can try to address them in the training. Given the time that I have, I do want to address some specific concerns. And if there's something that you'd like to get out of this training, I'd love to just see a couple of sentences or a couple of words even in the chat on what that would be. What concerns do you have? That could be number one. And what would you like to get out of this to reduce those concerns? Number two. I'll give you a minute to type those in. Knowing whether other clients, does art help with psychosis? Sample handouts are taking care of you there, Linda. You have some of those. And when people for CH are ready for CBT, are there times when people are too symptomatic? That's a great question. Yeah. Where can I find the chat? Is this the chat? You got it, Ashley. Deeper skills, measure client progress. Good. Okay, Krista's already a fan of CBT, so I don't have to worry about them as much. Oh, okay, crisis, yeah, CBT and crisis. That's a really great. That is a different approach for sure. Can be done, but a different approach. Probably you don't do all of the areas. Okay. Great. Okay. Perfect. We'd love to hear about the evidence support CBT with psychosis. Yeah. Differentiate between a highly imagination or the beginning of psychosis, specifically in adolescence. It is a different training altogether, one that I do. I'd happy to discuss that more with you, Amy, if you want to schedule some time. Brian, I think it's Brian. Brian wants to know if it's similar to trauma focused. There is a lot of similarities. I would actually argue that a lot of the techniques for CBT are very similar, kind of across the symptomology or quote unquote disorders with different techniques. There's my cat. This is one of the challenges of working from home. Okay, great. I appreciate that. That's helpful for me just to understand what concerns may be and what you'd like to get out of this training. I did see I'll address a good portion of those. If for some reason I don't, I do encourage ongoing discussion. So you send me an email. You know, my students like to talk about this. My family does not. I don't get a lot of opportunities to talk about CBT or something that I'm really passionate about. So I'm happy to answer some brief questions for you all. The first point that in CBT is that we have to sell it. That there was a question about how do you know if somebody is ready? There's a couple of ways to do that, and that specific question really buys into this kind of first topic of CBT. Now, for those of you asking about crisis, this might not be what you do, but for those of you doing ongoing CBT process, it's got to be quote unquote sold, meaning the client needs to buy it. Now, there's a couple of ways that you do this. One, we don't just throw somebody into a cognitive behavioral therapy practice. We want to make sure that the individual understands at least basically what the intervention is. They don't need to know all the theory. They don't need to know who Albert Ellis is. They don't need to know who Aaron Beck is. They don't need to know that, but they do need to know kind of the basics of CBT and what the intention is. I sometimes say, think about it as if you were able to prescribe a medication, you wouldn't just give somebody the medication and say, see if this works, or you shouldn't anyway. You would do the same thing. You would describe what the medication is, basics of what it does, and what it's supposed to help, and hopefully how it relates to goals. You'd be doing the same thing with CBT. You'd be saying this is a therapy technique that helps modify thoughts, sometimes behaviors, sometimes feelings that seem to get in our way of meeting our goals. We do this through weekly sessions. We do it through home practice, meaning that I will give you activities that I want you to try during the week. I will be following up on those activities, and we'll be measuring whether or not your goals are going to be reached. Go into a little bit more detail, a little less detail, depending on the kind of the cognitive ability of your client. But what you really want to get is some buy-in. And I'll do this by asking the client on a 0 to 100 scale. 0 meaning not at all, you're not at all interested, and 100 that you're 100% sold on this. How helpful do you think this technique is going to be? And I really look for 70 plus, to where I really to help me kind of understand whether or not they believe that this technique is going to be helpful. When someone asks whether or not we know, it's really going to be led by the client. If they don't think it's going to be helpful, they're giving you a 10% to 20%. You can ask a question like, okay, well, if you're at 20%, why aren't you at 10%? To kind of see if there's any kind of glimpse of hope. But it might mean that we're going to have either spend some more time selling it, or it might mean that we have to explain it a little bit better to see if that increases the score. Or it might mean, and as much as I love CBT, that is not the right technique for them. And that's okay too. That's, again, probably my best answer or my shortest answer on how we know whether or not CBT is good for a client. It's whether or not the client believes it's good for them. And we really do want to measure that. The two primary predictors from the CBT research and whether or not it works, and this is across disorders, whether it be psychosis, substance use, trauma, is first and foremost, does the client believe it's going to be helpful, meaning that they have kind of almost a relationship with the intervention? And two, does the clinician believe it's going to be helpful? So the more that you believe in CBT or whatever intervention you do is predictors of a positive outcome. So we want to talk, when we could say things like there's good research on its effectiveness with depression and anxiety and substance use and trauma and psychosis. We know that some individuals with psychosis don't think they have psychosis, and that's really the definition of psychosis. And so in those clients, they might be making statements like they're being followed by the FBI, there's cameras in their home, people are stealing their thoughts. I might say that sounds incredibly anxiety provoking. I can use this technique, or we can try this technique to see if that helps reduce your anxiety around the fact that you believe you're being monitored by the FBI. Again, CBT's goal isn't always to get rid of the symptoms, particularly when it comes to more persistent levels of psychosis, but help the individuals function when they have the symptoms. So we do get really goal-based when that's how, at least one example of how to introduce it. Here's some links, and I know you got the slides, and so I just want to give you, without kind of watching these, I kind of did my introduction. There's a couple of video links here that you can watch at your leisure to see examples of introducing CBT with psychosis. So if this is something that you do want to do, I encourage you watching these videos to watch some of the other pros really introduce CBT with psychosis. And again, this is not black or white. Don't take these as scripts, take these as ideas. And as you're watching videos like this, think about your client, think about what the trainer is saying, and to see if that would work for one specific client or not. And you'll find that, okay, that might, and the other might be like, that would never work with the client I'm working with. I'll have to modify that. So I want you to be thinking about that. So please don't think these as absolute scripts, but just to give you some ideas around how you would orientate or introduce individuals to CBT or CBTp. Okay, first step. That was the first step. We don't do CBT without introducing it. We don't do it without getting some buy-in, both from you as a clinician or you or the client. If you work for an agency that mandates CBT and it's not your thing, I would say don't do it. Find your thing. The research is incredibly clear that interventions have very little to do with change. We know that relationships is the strongest predictor, and that's really what we want to be thinking about when we introduce any intervention, but specifically CBT. Some people have beliefs about CBT that it's not relationship bound, it's more has to do with technique. Just not at all true. We need to build that alliance and relationship before we do any technique, and that's true for CBT as well. And I'll give you techniques on how to do that. One thing we do want to explain to our clients who will be joining us in a CBT process, that it does have a structure, that there will be some predictiveness to it. For individuals who have experienced trauma, individuals who are psychotic, we find in those specific populations that structure is helpful. The structure doesn't actually take away from the relationship aspect of the therapeutic alliance. That actually enhances it, actually can reduce anxiety when clients know what they're expecting in therapy. Unstructured therapies tend to not work as well with individuals with trauma and psychosis. It's anxiety provoking to go to the therapy's office or meet with your therapist when you don't know what's going to happen. This is predictable. They know what's going to happen. Reduces anxiety, puts them in a space where you can do better work. We do want to explain that there is structure to CBT. So we kind of talked about why we maintain a structure, just did that already. Now, that being said, it's not rigid. Structure is flexible and responsive. We do have an agenda. I mentioned the importance of having a whiteboard. When I would do work in CBT, my clients would see my agenda up my whiteboard in my office. I also did work in the field. So I had one of those mini whiteboards that I took to people's homes. The whiteboard was everywhere. And as we've transitioned to Zoom and GoToMeeting and Teams and all these online structures or online platforms, majority of them have a whiteboard feature. Or at the very least, you pop open a Word document, share your screen, and you do it that way. So this can still be done remotely some of you are still in that remote world. And I did see Zoom just added a more robust whiteboard feature, which is cool. So it is still flexible, it is still responsive. We do change the agenda. We have an agenda in mind. We ask the client if that makes sense. If they say no, we make the modifications. And certainly if somebody is in crisis, and even if they're a longstanding client and they're talking about suicidality or their symptoms are worse, their voices are worse, we can shift gears and focus on that. We don't have to be overly rigid. We're also keeping a structure that is flexible and responsive to the client's need. But that being said, there's a structure. Structure is both at the micro level and at a macro level when it comes to CBT. The structure at the macro level is following the order of CBT, which is the idea of we're building relationships. We don't start the CBT process until the client knows what they're getting into and that they trust that what we're doing is at least they have some belief that it's going to be helpful. That's part of the structure, and we don't get to interventions until until the alliance is set and until we've talked about assessments. Then we get into interventions. We kind of follow that structured order at a macro level of CBT. At a micro level, the structure is the agenda, what you're doing on a day or week to week basis. One of your handouts is the CBT for phases of treatment, guidelines, and checklist. And I forgot to mention a previous one. There's also a handout that I provided you. It gives you how to introduce CBT. So there's a CBTp, there's a script in there that you can use when you're just introducing it to a new client. There's also a script in there that gives you how to introduce it when you have an existing client and you're shifting interventions. Sometimes people worry about that, say, oh, I don't know if I want to start something new. We've been doing this other therapy forever. My response to that would be, is the other therapy working? If the other therapy isn't working, maybe we should shift. So anyway, that introduction is there. And then I also have included your CBT for phases of treatment guidelines and the checklist there, which just kind of gives you an idea of the macro structure of CBT. All right. Elements of the micro level of the structure in CBT are going to involve a check-in. We don't usually jump right into therapeutic processes. We like to check in. We like to do some socialization. We find that this reinforces attendance. And you also have the opportunity to check in on any major events, mood changes, red flags. It allows you to address any immediate needs. Client comes in and starts talking about feeling suicidal. You can do a quick check-in on that or refer them to crisis if you need to. And that you can also do a symptom check-in, but it's key to do some form of check-in. And I'd say, and I strongly advise that socialization is a big part of this, particularly in CBT with psychosis. Another cognitive issue that exists in schizophrenia in particular is the loss of social cognition. That ability, it's almost like a late stage, if you want to think about it like this, late stage autism, where the individual struggles with recognizing social cues, struggles with initiative in terms of wanting to relate to people. So you doing socialization is essentially part of the treatment efforts in which you're modeling how you check in, how you introduce yourself, how you have some general topics to talk to others about. That is part of the treatment. Students sometimes say, well, just kind of chatting with a client, talking about their weekend, talking about their week, am I really doing anything? So you're absolutely doing something. One thing that most people want in terms of goals is relationship. One of the strongest predictors of therapeutic or a resource that predicts good prognosis is the amount of support that individuals have. You're working with them to help maintain support or develop new supports. So, and that can be just talking about what might be considered benign topics, might be talking about the most recent Marvel movie, might be talking about a book that they've read, music they're listening to, something along those lines. And that's essentially part of the treatment. All right, agendas can vary, but agenda can look something along the lines of one, check-in, review of your last session. We consider that bridging. We want to make sure that whatever we taught in the previous session or whatever the client learned in the previous session is reviewed, because we want to continue. That's a skill we don't want them to lose. We can review home practice. Home practice is a big part of CBT. You'll notice that I'm not using the word homework. I've just personally moved away from it. I work with a lot of adolescents, And homework tends to have this negative automatic thought associated with it, where something like practice doesn't seem to carry the negative cognitions in the same way. So using that term over the term homework, even though in most CBT manuals or materials, you'll see the word homework, I just replace that with home practice. Once that's reviewed, we go to new material. We summarize the session. I summarize the session by asking the client what they've taken out of the session versus me saying, oh, we talked about negative thoughts, we talked about stinking thinking, we talked about behavioral activation. I don't do that. I want to hear what they got out of it. What are 3 of the gems that you take away from today is an important question. I had one client that essentially wrote her own progress notes where she would write what we learned, and I would actually cut and paste those into my notes really to show that what she was taking away. But it was remarkable to me how many times I thought what they took away was not what they actually took away. And that's just important for us to understand. I mean, many times, oh, we talked to the client about that. We might have talked to them about it, but that's kind of like, if a tree falls in the woods, does it make a sound? It's the same type of question as if I've taught a client, did they really learn it if they didn't completely memorize it or completely get activated in it? So we do want to make sure that clients are taking away something from the materials. And if they didn't get what we wanted, we can go back and review it again. And then you assign new practice. So the agenda should be set prior to the session. Have that up there. We ask when the client comes in as part of the check-in, we ask if the agenda makes sense for today, if there's something else they want to talk about or make a modification, we can do that, but we get the buy-in on the agenda before we get started. So we'll kind of work our way through the agenda components. We've done the check-in, we've talked about that already. We do want to follow up on the last session. The techniques on that is a teach-back technique, where we ask the client to tell us how they used whatever we talked about from the previous session in the last week. We'll check in on any additional thoughts and reactions. We'll reinforce the work that they did, personalize it specifically to their goals. Oh, thank you for completing this the cognitive triangle here. How was that useful to you? Was it useful to you? Was it not useful to you? If there was some misunderstandings, if they didn't understand what you were trying to portray, you can address those and ultimately extend the learning. There is no pressure. This is kind of the flexibleness of the agenda, that you have to get through all of the modules, all of the information through a certain number of sessions. We want to go at the client's pace, slow down. If they didn't get something, we can do it again. Repetition isn't bad. Repetition is important. Repetition is how we learn. We would explain that as well. And particularly in cognitive disorders like schizophrenia, repetition is essential. We may have to repeat what we've already talked about or add another example to it. Home practice review. That should be a standard agenda item. That should be early on in the session. If the client doesn't get a sense that you're prioritizing the home practice, then they're not going to prioritize it. If we just skip over it, they're going to wonder, why did I do this? See if the client can verbalize the rationale for the home practice. Do you remember why we decided on doing this activity? What was it related to? Ask them how it went, get some of the details. Any attempt, even if they didn't do the home practice completely, should be reinforced. Ask what they learned, what was useful about it. Ask what was not useful about it. Troubleshoot. Now, I imagine what a lot of you are thinking is, well, I have clients, I've done home practice, rarely do they do it. That's fair, and honestly, it's true. A lot of research shows that about 50% or less of clients complete the home practice that is assign. There's a couple of techniques to this. One, if they don't do the home practice, we don't forget about it. We still prioritize it. We just do that in session. That becomes what we do for that in-person session, or that Zoom session, I suppose. And we'll just do the home practice exercise or modification of it. Or if it was done not in a way that you had explained, then you do it again. And so a home practice always gets done. If it's not done outside a session, then it's done in session. That's one technique. I also like the preventative technique that really helps, hopefully increases the likelihood that someone's going to complete their home practice. That's the, now I'm forgetting her name, Beck's daughter. But hers was which was called the Beck rule, which was you would ask the client after you've assigned the home practice, what's the likelihood that you're going to complete this, again, on a 0 to 100 scale? If it's anything below 80, you do a different assignment based on the fact that it's less likely to be done. And you talk about it like this. You own it. You're saying, you don't kind of say, what could be done for you to get this done? You say, sounds like I haven't come up with an assignment that you're going to find helpful. Let's think about what might be a different assignment that I can assign. There's a lot of responsibility taking on the part of the clinician in CBT. You're responsible for coming up with the home practice that is likely going to be done. And if it's not done, you share some responsibility in that by saying, oh, so I hear you, it doesn't sound like you got the home practice done. Okay, sounds like I didn't come up with a practice that you found useful. And they might say, oh, it is useful, I just didn't have time. You could say, well, then that's the next time we talk about home practice, we'll try to work it into your schedule. Let's go ahead and do it today so we don't lose a really important activity or an important piece. Come prepared with an idea of what skill you're going, introducing new materials, another agenda item. You want to come prepared with what you're going to do. Again, part of this is all part of the therapeutic process. Clients know what to expect. They know there's going to be an agenda. They start to learn that home practice is going to be reviewed. They know that there's going to be a new activity. They know all this. That's set up before. And I fully recognize the amount of pressure that we're all under and the amount or lack of time that we have. I just really encourage, just stick to maybe the 45-minute, the 50-minute session, so you do have time in between clients to get your new material either up on a whiteboard, on a mobile whiteboard, or up on Zoom before the client gets in. Again, that's part of the therapeutic practice. Reducing anxiety, reinforcing the structure is all there. Whatever material you do is based on the phase of treatment. And we'll get to phases of treatment in a little bit, but if you're still in the engagement phase, then it's an engagement activity. It's not a CBT skill. If you're in the assessment phase, it's completing a formulation. It's learning about a new assessment. It's reviewing an assessment. Interaction with the client is key. It's unfortunately not like this, where I'm very much lecturing to you. It's much more interactive. So it is doing role plays with your clients, have them practice the skill. You demonstrations, you demonstrate what the skill is. You do a little bit of disclosure, what you feel comfortable with. You kind of talk about your own automatic thoughts. You talk about your own levels of depression in some ways. Teach backs are key, where you have the client teach back what they've learned. Use of videos. There's some really great CBT videos. I have links in this training that you can use that we'll watch with clients together to demonstrate a technique. And if it's engagement, we might be watching their favorite YouTube video. And they're telling me about it. Again, that's an important social skill. Then make sure, again, all examples are appropriate and, again, relatable to their goals or interests. Types of home practice. This could be listening to sessions. One cool thing about Zoom is I can give home practice of saying, I want you to rewatch minutes from minutes 15 to minutes 30 in our session. Could just be reviewing it and then tell me what you've taken away from it. It could be activity scheduling, which is a form of behavioral activation. Self-monitoring, that might be monitoring negative thoughts. If you're trying to work on addictions, it might be monitoring, how much they're smoking cigarettes. If it's voices, it might be monitoring how often a severe voice happens and when it happens. There's a wide number of worksheets you could assign. There's family-based home practice interventions. I'm big on really including family and whatever family is to them. That could be friends, could be families they choose, but engaging the social supports in treatment, assuming they allow you to do that. If you work on a interdisciplinary team, maybe you involve the case manager, the prescriber, the skills trainer, the peer support. If there's other individuals on the team that you could have them help you with home practice, that's great. I mean, part of we would do those weekly or daily team meetings where we go over the clients for the day. I would say, I know I've worked with Ryan, he has the home practice of, walking to a gym. I just wanted him to walk in. I'm wondering if if the skills trainer could help me get Ryan to the gym, or something like that. So really involve the treatment team. Get the treatment team understanding what you're doing as part of your work, and get them involved with it. Gives them some structure too. Another agenda item is the session review. These are educational strategies. They're crucial to encoding and consolidating the work of the session. It's not just see you next week. We end with, what did we learn today? What did you take away from today? Tell me 2 gems that you think you can use. We can do this verbally also, or we can do it written, which actually I like. The one item that I provided to you in your packet is the SAF, which is the session assignment and feedback form, where you're really kind of checking for the understanding and having them write it down, or you writing it down together. Again, that enhances another form of learning. Remember, when people write things and hear things, they retain it more than you just saying it. Oops, I'm sorry about that. This kind of additional information on the session summary is up there. Here is an example, just so you know what form I'm talking about. This is the session assignment and feedback form. It includes what their home practice is, when they're going to do it. So as a calendar, what are the 1 to 2 things that you remember from the session? Again, I use the word kind of gems or nuggets. What did you find unhelpful, unclear, or bothersome? You also want to hear what didn't work, so we can repair that. You might be thinking, I don't know if my client will feel comfortable telling me what was unhelpful, unclear, or bothersome. If they aren't feeling comfortable doing that, that's on us as the therapist. Part of what we want to do in CBT is create a culture or create an environment where the client does feel comfortable giving us feedback, because that's how we know what's not working. Otherwise, clients will will talk with their feet, and that is in the form of no showing, not showing up, moving away from the CBT process altogether. So when a client does give you any form of feedback, you want to reinforce it, and you want to introduce this. You want to tell them that it's important for me to hear what didn't work, because that's what's going to help you reach your goals. I can take it. Even if it's that I did a terrible job today, I want to hear that. And you really reinforce it, you own it, you move away from blaming the client and taking responsibility for the contents of the session. And then what do you want to discuss next session? That could be, you can inform the home practice, and then how helpful were the assignments, and there's a rating scale. A lot of rating scales in CBT. This isn't my form, this is just a form you can use if you want to. I'm not 100% familiar with the research around this. What I am familiar with is the research around clients feeling safe to provide feedback. That's also predictive. An article I encourage you all to read it's actually out of the New Yorker. I know, not a high academic journal, but it's a great article that's titled Super Shrinks. And I can send you a copy of it if you're interested in it. And it kind of talks about what predicts really good therapists, essentially who are the super shrinks. And it's the shrinks, or the therapists that got poor outcomes early in their treatment were better long term. The author's theory around this was it's not the techniques. Most counselors, therapists, social workers, psychologists are trained very similar, especially when it comes to specific techniques. I train CBT the same whether I'm training it to students or whether I'm training it to psychiatrists. It's all the same techniques. Everybody gets the same information. If it was about that, then essentially everybody should get similar outcomes, but we don't. Some clinicians, counselors, social workers get better outcomes than others. And what this article pointed out, and it was based on research from a more advanced journal, was those that got the best outcomes were the ones who got negative feedback or negative outcomes early. And the idea was that they created a culture in which the client felt safe to say what wasn't working. So the therapist, counselor, social worker, psychologist could make the change. It really was about that culture. So something like this is really essential. Again, I would say it's essential in all forms of treatment, but since we're talking CBT today, it's absolutely essential to hear what wasn't working and to create a culture where the client feels comfortable telling you that. Oops. I was going to take a break, but I'm ahead, so apologize for that. Not taking a break yet. We'll take a break in about an hour. All right. So now what we have talked about, what we have learned, so this is a little bit of example of summarizing the treatment. I try to mimic my trainings to match a CBT session. I did set the agenda. One thing I didn't do, and I tried to make it somewhat collaborative. I did ask you about what you wanted to learn, same type of things that you would be doing in treatment. We have talked about, explaining CBT. We've talked about some of the macro structure of CBT, which is the overall structural process, which is these phases, which we're getting into now. Talked about the microstructure of CBT, which is the agenda setting. And we've talked about the importance of feedback in creating a culture where the client feels safe. All right. What I would like to hear now is it's definitely techniques to, the session rating scale is something I use as well. I actually use that sometimes in lieu of the form that I just showed you. So thanks, Mike, for bringing that up. So just to model what we've already talked about, what 3, 2, 1 nugget, if someone could write one nugget, one gem that you have taken away from what I've just talked about in the last hour or so. Put that in there so I can get a sense of what you are taking away, and then see if it kind of matches what I was hoping you would take away. Let you take ownership. Okay, that's important. Okay, some techniques, doing unfinished homework session together. Yep. It's key. Collaborative. Home practice versus homework. Phrasing, yeah, language is important. Language changes thinking. So, late stage of autism, Amy, yeah, I'm happy to, if you want to email me, I'm happy to talk about that. Autism. Reinforcing the relationship does a heavy lifting room. I love that statement. It's great. Practice, yeah. And I love that some meet them where they are. When clients reflect on the session. Okay, great. Definitely taking away what I was hoping you would take away. I love the kind of advanced thoughts on the Scott Miller techniques. It absolutely is. I'm also a certified feedback informed treatment provider. I am a colleague of Scott Miller's, written a book with him, and involved with his work as well. So it gets incorporated into everything I do, for sure. All right. Not rushing, absolutely. Don't have to rush this. I mean, I think a lot of clinicians feel pressure to do change quickly, otherwise they're not effective. Change can be slow. What we really want to look for is change, not rapid change, change. And we'll talk about that when we get to the assessment phase. All right, close that out and get going. Looks like people are getting a good sense of what I'm trying to cover in at least that first structural elements of CBT. Now we'll move to the macro level of the structure of CBT. It's kind of these 4 phases. And it's important in CBT to go in order. Again, this is the difference between fidelity-based CBT and CBT-informed practices. Almost everybody gets some form of CBT in graduate school. They learn a couple techniques. Mostly they learn something, they learn cognitive restructuring is probably the most common technique that people learn in graduate school, the Ellis form of CBT, the rational emotive behavioral therapy, which is a form of therapy that falls under the CBT umbrella. Some people just call it CBT. It's really not. It's REBT, which it falls again. CBT is a larger umbrella, which has different techniques. There's the Beck form of CBT, and then there's the Ellis form of CBT. Then everything else kind of breaks off from those 2 forms. But the key is in CBT is when we look at the studies that show effectiveness, and there's a ton. I mean, it's the most studied technique in the world, and it's been studied across all forms of interventions and showed effectiveness. Now, let me just kind of speak to the caveat to that. Why CBT is one of the most studied techniques in the world is because it's a structured technique. It's easy to study. So because I can watch videos of CBT practitioners following a CBT manual and I have a fidelity checklist, I can check that off and say, yep, they did that. Yep, they did that. Yep, they did that. Yep, they did that. They're doing CBT. That's harder with emotion-focused therapy. That's harder with more of the psychodynamic forms of therapy. So again, I'm a CBT certified trainer and clinician, and I'll be the first to say that CBT is not the be-all and all. It doesn't work for everybody. If you don't get that buy-in, then it's probably not going to work. And I'll also say that CBT is probably just as effective as any other technique. It's just the most studied, so it gets the most credit. And the reason why it's most studied is because it's easy to study because of the structural elements to it. So, and when we get these positive outcomes with CBT, the majority of the studies in CBT is people doing fidelity-based CBT. They're going through these phases. I've heard from many clinicians, students to say, well, CBT wasn't that effective. And I'm like, tell me about that. And they said, well, I pulled out the thought records and I had them kind of work through that. And I said, well, that's a CBT informed technique. That's not CBT. It's not what the studies have done. Studies, again, fidelity based, followed the manual, everything else. And that's where they got the good outcomes. Again, not that CBT informed practices are bad. I think they're great. But again, I just want to make sure when we study, we talk about the effectiveness of CBT. We talk about the the structural components of it, kind of going through the whole module. So again, CBT can work. Studies have shown that, but again, the studies are fidelity-based CBT work, what I'll be talking about today. All right, yeah, so let's kind of talk about the phases. We'll start with engagement. Again, dispelling a myth immediately that CBT is only a band-aid technique. I've heard that doesn't get to the root of the problem. I've heard that criticism. Notice my cat in the background who heard me talking to people and said, hey, wait, I want to get involved in that. It does involve that. It does relationship building. It does involve getting to the root of some challenges. So it's a complete myth that CBT is a band-aid technique and doesn't really get to the root of problems. Full fidelity-based CBT, particularly the vet version of CBT, absolutely does. But let's start with what has to be in place, which is that relationship, which is done through engaging the client and is part of the fidelity-based CBT. And I think really essential when it comes to CBTp, because of just the lack of social cognition that exists with psychosis. We might have to spend more time on this with that population. Click. Oh, and then certainly engage natural supports, whether that be family, whether that be support systems throughout. That really just demonstrates the importance, plus helps reinforce what is a predictor of positive outcome, which is support systems. All right. One thing we have to talk about when we talk about engagement is those barriers to engagement. We need to be asking clients about this. What has gotten in the way of successful treatment for you in the past? Most clients that we have had some form of treatment. I'm using a lot of examples from individuals with psychosis. Some of the negative engagement processes are negative experiences, that they've had with mental health systems. You know, some have had negative experiences with mental health. They've been institutionalized, and for, I would say, the majority of individuals with psychosis who've been hospitalized, it's not a positive experience, at least not initially. Misconceptions about what treatment is. They've had, especially if they've been hospitalized, treatment in the hospital looks a whole lot different than treatment in outpatient. Psychiatric symptoms certainly can get involved. We'll talk about that. Cognitive impairments, secondary to psychiatric symptoms, already been addressing that with schizophrenia and psychotic disorders. Medications can be a barrier. Many of the medications, particularly with psychosis, cause sedation, cause cognitive challenges, cause negative symptoms, cause motivational problems, brain injuries, other factors, simple mistrust, beliefs that's not going to be helpful. Stigma, that they don't want to seek treatment because it feels stigmatized, particularly self-stigma seems to be more predictive of stigma in general of negative outcomes. Shame, and then expectations based on past experiences. Didn't find it helpful, so they don't want to try it again. And I've had clients with CBT where I've said, I'm going to do something called CBT. And I said, oh, I've done that. It wasn't helpful. I said, oh, tell me about that experience. What did you do? And I usually explain that what was done was CBT informed practices, wasn't full CBT. Would they be willing to give me a shot to try it again with the full package, so to speak? And again, if they're like, nope, won't do it, they probably shouldn't be doing CBT. If they're willing to give it a shot, score 70 or higher, and sometimes I'll negotiate, give me 2 months, let's see where you are. And if it's not working, I'm happy to change, because it should be working. Definitely should be working by that time. And so what are we trying to do in engagement? Trying to get to know our clients. It's not going to be surprising to any of you. Build rapport and develop a working alliance. Some people do confuse the term alliance with relationship. Relationship is a part of alliance. It is not fully alliance. Alliance has to do with the relationship, for sure. We call that the bond between you and the client, but it also has to do with a shared understanding of the tasks and the goals. And this is why CBT focuses so much on introducing itself, having the client understand what you're going to do. That's the task. And it's a shared understanding of the task in therapy. That's all part of alliance. So when you hear your professors or you hear trainers say alliance or relationship predicts outcome, it's not just relationship, it's alliance that really predicts outcome. The bond between you and the client, the shared understanding of what the task is, that you have a shared understanding that you're going to do CBT, and that you both have a belief that it has the potential to be effective. And then the goal, a shared goal, that you both have a shared understanding of what the intended goals of the intervention is. This is kind of that shared treatment planning process that the client can say, if I part of a Fidelity-based CBT measure is the client being able to say what CBT is, at least from their understanding, what the goal of CBT is from their understanding, and do they have a trust for you? So alliance, task, goal, bond is really what we're looking for there. You've introduced CBT to the client, whether it's through one of the videos that I've showed you or you talking about it, following the script that I've sent you already. You present the opportunity to normalize the client's challenges. And that can look like, even when it's, something like hearing voices, and be, we all have voice, we all kind of have that. I mean, sometimes those can be helpful to you. And I can also understand why you would have those experiences based on your past. Kind of normalize, you can't normalize their experience. Could also try to normalize voices and negative thoughts to clients or delusions, and they say this isn't normal, and so you don't want to normalize something that they actually perceive as abnormal that they actually really want to treat. And then there's clients that are kind of part of a neurodiversity movement, that see their voices as a different form of cognition, and you would want to normalize that. But other clients are, I want these voices to go away, and you would what you're normalizing there is the level of distress they would feel because of the voices. So again, we have to understand the person's client. That's part of building that relationship. We have to understand the relationship with the experience, with the symptoms of the client. That then allows us to appropriately normalize. If they feel it's a pathology, if they feel that it's something negative, then we normalize that experience based on the symptom. If they feel that the symptoms are part of neurodiversity, part of them, then we normalize that experience. So we do need to really explore the client's understanding of their symptoms. Sometimes, particularly in psychosis, it's a lack of understanding of the symptoms, meaning that they believe what we call symptoms as being real. So they believe that the FBI is tracking them. They believe that people shapeshift, and that's causing significant distress. Again, we don't at that point start talking about changing the delusions. We start talking about how the person can live and cope in a world where they believe people shapeshift, and how distressing that is. What you can normalize is, if I had people shapeshifting around me, and it's okay, and we don't want to collude, we don't say it's real, we're saying, but if I had that experience, I would be under significant distress also. That's the normalizing feature there. We want to know what they've used to cope already and point out maybe things they don't recognize. Get the clients to help you identify family members, other significant others, family they choose, they might be willing to engage in treatment. Again, strong predictor. One of the strongest predictors of outcomes in the project that I led in Oregon for so many years was one of our more positive correlation was the number of trusted social supports that the client had. So if anything in treatment, let's try to build social supports, because that was more predictor of whether or not they were going to even engage in the intervention. So support is absolutely essential. So we want to build that. So I'm not one, and it's okay if you are, but I'm not one that says, I want this to just be me and the client working together. I'm one that I want to get releases right up front with anybody that the client trusts. Certainly if they don't trust the person, that's not someone I'm going to be working with. But I do want to get releases right up front, early on in this engagement phase with the client and that might be our work for the day. That might be what's on the agenda. Let's talk about who you trust. Let's talk about who could help you or who has helped you in the past. Let's think about someone that's not in your life anymore that maybe you'd like to get back. Patricia Deegan, one of the long-term schizophrenia advocates, talks about kind of the power of 5, which is a client's ability, or actually any person's ability, to be able to name 5 people that they could call or text or connect with 24 hours a day, 7 days a week, and that person would do their best to make themselves available to help you. And that from her understanding, from her research, from her work, the closer you are to 5, the better the outcome. So, I mean, most of us might be able to think about that and think, yeah, I can name 5 people probably who I could text at 3 o'clock in the morning or call at 3 o'clock in the morning, and they would do their best to help me if I was in a crisis. And then certainly listen and ask questions. Try not to be directive at this point. We're listening, we're understanding, we're asking clarification in the engagement phase. Certainly, we want to be culturally humble in our practices. We know the evidence on cultural differences between the therapist and the client, and that should be acknowledged. So we can acknowledge those differences. We want to acknowledge the power differential that does exist. We want to make sure we align with the person's goals using their language. We certainly don't want to pathologize culturally normative beliefs and behaviors. Someone mentioned in the chat earlier trying to distinguish the difference between an adolescent imagination and psychosis. Yeah, we don't want to pathologize what would be considered adolescent imagination. And we see this in autism quite a bit. We see individuals who have autism that sometimes get perceived as being psychotic. And some individuals with autism get so caught up in their worlds, their quote unquote fantasy worlds, that it seems psychotic. They'll talk about being related to or having relationships with celebrities because they're so into that celebrity, but it's actually not delusional. It's a world that they have created because they struggle so much with connecting socially with their peer group. So they've kind of created this. That's in some ways a kind of culturally normative belief. You know, I've worked with individuals who believe that they are kind of part of this vampire group. It's not psychotic. It's a group that they're hanging with. I've had overvalued ideas and overinterest in Pokemon and a wide range of kind of cultural phenomenons, and that I want to understand that. And again, if it's how I differentiate between a kind of culturally normative belief and a psychosis, a couple of things. One, is it, first and foremost, is it causing them or others significant levels of distress? Psychosis causes distress, causes functioning problems. Imaginations and cultural beliefs that we don't understand are generally welcomed in the person's life. Others within their social supports do those behaviors. Psychosis, the social supports will say, this is not my child, something is different. Where social supports within a culture say, this is what we do, we're supportive of that, even though you may not believe it. So that's one way that I differentiate. There's some other techniques as well, but that's partially how I differentiate between imaginative and cultural behaviors versus psychotic behaviors. Again, why this is important is we don't treat culturally normative behaviors. We treat psychosis, we treat depression. We're going to hold the hope that, you know, we can say things like these techniques have been helpful for individuals with your experiences, from your backgrounds. We want to personalize the treatment. We want to use the client's language. You know, if they're using, again, I've worked years with individuals with psychosis. Those who had severe or true psychosis never used the term psychosis. So I didn't use that term. I'd use things like extraordinary beliefs, beliefs that cause stress, you know, anxiety beliefs, or just general anxiety. So you want to use the client's language to kind of keep them engaged. Certainly involve family, consult faith leaders if you need to, as long as you have permission to do that. I've done that a handful of times. Make sure you clarify any misunderstandings, misconceptions about treatment. Give clear, simple examples. Again, when you're describing CBT, use yourself. I mean, I use my own examples of thinking errors when I start describing thinking errors. And then, generally be genuine, honest, transparent. If you don't understand something about one's culture, say, I don't understand it. Doesn't mean I can't be helpful, but it does mean that I don't understand, and I may need to hear a little bit more about that. And again, to add structure to that, I'm a big fan of the cultural formulation interview. I don't know if I included that in your packet, but you Google it. It's a free resource. It's part of the DSM-5, and it's a way to ask questions about individuals' cultural experience. It's a very nice tool. It uses non-pathological language, as well as just it's not assuming language at all. So I really like that tool to understand individuals' cultures. Actually, I've started using it with everybody, not making assumptions that, oh, I'm seeing another white person, they might be just like me. Culture is broad, culture has faith, culture has beliefs, culture has experiences. I think it's a nice engagement tool that I use early on in CBT.
Hi, Dr. Melton. Had somebody ask if you could please repeat what we don't treat, and if you could also repeat the name of that cultural tool.
Yeah, it's a cultural tool, cultural formulation interview, bolded on the slide right there. And the other question was what we don't treat. So what we don't treat is we don't treat culturally normative beliefs. I'll give an example. So I had a adolescent female who was referred to me because she believed in ghosts. The person who sent that individual to me wanted to know if they were developing a psychotic disorder. In doing the cultural formulation interview and some other engagement techniques, as I was going to do CBT with her, I learned that one, the ghost that she was seeing was her grandmother. Her grandmother had passed away not too long ago. And she would talk about her grandmother coming to visit her and would kind of stroke her leg in a compassionate, caring way, something her grandmother used to do. I specifically asked her, or when I summarized it sounds like that this is really supportive to you to have your grandmother come visit you. And she said, yes. And I said, if I could do techniques that would stop your grandmother from coming to visit you, would you want me to do that? And she said, no. So, and again, I also did some additional other exploration to learn that this wasn't causing her any functional difficulties. She was still making it to school on time. Her grades were okay, but they hadn't changed. So what we don't treat is, culturally normative beliefs and behaviors. Another thing we don't treat, which I touched on, but I think it's really important, is if you are doing CBTp, so individuals with psychosis, what we don't treat is an individual with kind of really what seem to be fixed or rigid beliefs around their psychosis. So at that stage of the treatment, we don't try to treat the delusion as a thinking error. What we then treat is the stress or the things that are getting in the way that are keeping them from their goals. But we don't want to give a whole lot of education about, oh, this is psychosis and that's called a delusion. That doesn't tend to work with fixed or rigid delusion. So we're treating the stress around it, not the delusion itself in those cases. Other times clients will say, I have this belief, I know it's not real, but it really feels real at times. In those cases, we can do different strategies to address the delusion. Did that answer the question? I mean, I'll let me know if that got to the question, so you can put that in the chat. Another thing that's helpful engagement is the offering gifts. These aren't physical gifts. This isn't giving client maybe a physical thing, other than maybe I used to give out, I had a pile of rocks that had inspirational words on it. I sometimes give those to clients. But what gifts are quick skills that teach a client to bring down distress. And it's nothing major. They're not complex. They can create buy-in, and then I'll just give you some examples of what gifts are. And again, they're just skills that we do early on to bring down distress. We're not necessarily getting into all the CBT techniques. We're just trying to, at this point, bring down distress. Give you some examples. Put a couple up here. You know, these could be, I've got some art on my wall. We'll kind of talk about what that means. You know, we can use it as a grounding technique. We might go for a walk. Really like doing that with clients. I actually really like when we're especially working with individuals with psychosis, the side-by-side therapy tends to work a lot better than the face-to-face therapy. I found that to be very true, and it was backed up in the literature, particularly in young males who have psychosis. Me sitting down, staring at them, it's actually painful. It's probably doing more harm than good. We did a lot of side-by-side therapy. That would be taking a walk. One client, we actually went for a ride. We actually did driving therapy, listening to music during the session. You know, kind of activating individuals with schizophrenia in particular have what we call low sensory registration, which means they need some level of sensory input to almost get going. So having music playing during your session, just kind of at a low level, having sensory tech tools, whether it's a sensory box, whether it's a Rubik's Cube, whether it's other sensory materials just in your session, you will watch these younger people just grab those things and be playing with them during the session. I see that's them trying to activate their registration level so they can start paying attention. So don't worry about eye contact. Eye contact is probably the least predictive of outcome when working with individuals with psychosis. I was fortunate enough to have a nice view of a river in my office, so we did a lot of return together, and we both kind of look out the window together and kind of talk about what we see, what was going on today. I might say, let's see if we can, you know, at a street that was kind of to the right of me, we could see some cars going by. I'd say, let's kind of just look at the number of blue cars that go by. You know, can we count those together? Who do you think their story is? You know, we make up things about people in the cars. You know, just things to bring down anxiety. If you're skilled in mindfulness techniques, it's great, do those. There's the 5, 4, 3, 2, 1 technique, which I'm sure many of you are familiar with. Have the client name 5 things they can see, 4 things that they can hear, 3 things that they can touch, 2 things they can smell, 1 thing they can taste. You know, just bringing awareness to the sensory system. All techniques that you can do just to reduce stress, just to reduce anxiety in the session. We know we're going to get better outcomes if we can kind of get people in that sympathetic state. We know particularly individuals with psychosis are at a higher level of arousal when they enter sessions. Maybe that's based on past experience, maybe it's based on voices they're hearing, but their arousal is up. We want to reduce arousal early so we can then build off of that and move forward with the session. I won't play these, but you're welcome to listen to them. These are, I would do a name that tune game where I would play tunes, play music and have the client try to name the song. Then I would do it. He'd go on YouTube and look up songs and I'd turn my back and try to name that tune. We also got into watching kind of the favorite YouTube video, what the new cool TikTok was, learned a lot about TikTok from my clients. So those are all different things that you can do. Again, the goal is just to reduce arousal, reduce stress, reduce anxiety before you get into the therapeutic work. You're going to do better therapeutic work if the client is less aroused, less anxious. Breathing techniques. I mean, again, I'm sure many of you are trained in breathing techniques. Do those as part of your session before you start. It's a key technique in reducing anxiety. It's written into a lot of the CBT for or anxiety manuals of being part of the agenda is breathing. Get to the point where the client's teaching you breathing techniques. I use the Relax to Breathe app. where, that was part of our home practice, which was they would do certain activities on the Relax to Breathe app and then bring that into session, and they teach me what they learned from that app. Yeah, that would just be part of this engagement phase. An engagement phase, building relationship, understanding CBT, reducing anxiety. So those are other techniques. I would do some exercise techniques that have, people kind of touch their toes, stand up, do the kind of DUI thing, touching their nose. We do all sorts of different activities, kind of based on the client, what their interests were. Some of my clients just did not get into breathing at all, wasn't their thing. I'm not going to do it. And we did something more physical, or we'd watch YouTube videos, or we'd watch TikTok, or we'd watch or listen to music. All right. So that's phase one. That's really the engagement phase. We're going to move into psychoeducation and assessment here in a second, but to be congruent with CBT practices, give you a chance again to say what are a couple of gems that you took away from phase one, the engagement phase. I'll give you a minute or so to put in the chat there. What you're seeing. Now I've lost the chat. There it is. Okay. Okay, so people talking about the ideas of giving gifts. 5, 4, 3, 2, 1. Support systems. Okay. Yeah, reducing arousal, just key. Yeah, gifts is, I think, a nice term. I would use that term. I'm going to give you a gift, which is like a skill. Again, in CBT, language is important. Going into client space, yeah, absolutely. And yeah, we might want to stay in engagement for a little longer. I mean, there's clients where I did probably 2 months of gifts and arousal techniques. One client that in our sessions involved playing basketball and, doing 5, 4, 3, 2, 1 while playing basketball. I mean, this is something we had to do and get him to a point where he would even trust me to do therapy. He wasn't ready to do therapy. He said, therapy sucks. And I said, let's go play basketball then. Little did he know I was doing therapy while we were playing basketball. Yeah, side by side. Male adolescents with psychosis. Yeah, I mean, side by side was almost always the way to go. Okay. Looks like you're taking away what I would have wanted you to take away from this, so we can move on with the next phase of CBT, about a half an hour, from a break. Okay. The next phase of, oops, I don't want to quit the webinar. Push the wrong button. There we go. Next phase of CBT, we're kind of getting the psychoeducation and assessment. Psychoeducation is a part of CBT. So psychoeducation might be, and again, this has to be tailored too. Here's kind of my overall comment on psychoeducation. Psychoeducation that is not deliberate is a Google search. So say it again, psychoeducation that is not deliberate is a Google search, meaning that if a client wants to learn about their symptoms, they can go to the internet and type in schizophrenia, psychosis, anxiety, depression, whatever symptoms they perceive that they may have, and they can learn all about that. They can go to WebMD and they can learn about schizophrenia. They can learn about that, but it's only really relevant if it's tied to them. I've had people go on WebMD and read about schizophrenia, and then it says something like schizophrenia is a chronic progressive disorder, and that just completely self-stigmatized them. That's it. This becomes a Google search. Psychoeducation needs to be deliberate and tailored to the individual. And you can't really get to that without understanding their experience of their symptoms. So why we do the cultural formulation interview, why we talk about their relationship to their symptoms. And if somebody comes to me and they say, I saw a client the other day that was talking about their psychosis, they were using that term psychosis. They certainly did have psychosis, but they had now had kind of insight into it. They knew that they had a belief that Facebook Messenger was sending them messages to do things, was their belief. And they believed it with full conviction at the time. And then by the time I saw them, they were talking about, wow, it was really scary that I kept going back to the computer to see what Facebook Messenger was telling me to do, and who was after me. In that case, I can give very deliberate psychoeducation about what was probably happening to them, what was maybe going on chemically, use a lot of medical terms. Other people will say, that I am, I believe that half of my brain has been stolen. And I keep a cap on really tight to keep the government out of my brain. And I'm coming here to have you help me, keep the government out of my brain. Now that tells me this is a fixed, at least currently, a fixed delusion. And me going in and providing psychoeducation that this is a delusion and part of a schizophrenia process, I'm going to lose them. I need to be focused more on the role of stress and how maybe if they're really stressed, that stress can make that feeling more apparent. That they could be thinking about it more, because there were times in their life when they weren't thinking about it, and that was when they're most calm. So I can use psychoeducation that way. So psychoeducation really needs to be tailored. When you're giving psychoeducation anyways about symptoms, needs to be tailored to the individual's understanding of the symptoms. Otherwise, it can be quite scary and you can lose the relationship really quick. And I learned this almost by happenstance early on in my career when I was working with an individual who believed that a mafia was involved in them. They were outside their apartment, and he would have delusions of reference that on street signs and billboards that would somehow tell him that the mafia was watching him. So I learned really quickly I couldn't come in and give education about schizophrenia. Did a lot of work around, stress relief, how, coping skills, keeping stress low, what support systems, how support systems could be helpful to him around trust, those type of things. And I finally got him to a point where he was willing to take medicines more around reducing stress. And then I brought him to the psychiatrist. Psychiatrist within a minute said, you have a disease called schizophrenia. And client walked out, we lost a relationship with him almost permanently. He was in the hospital within like 3 weeks. So we have to be really careful with education. It does need to be targeted, because they can get basic information off Google. Our job as CBT therapists is to make the psychoeducation deliberate to the individual. Otherwise, it could be scary. I've said that already, but repetition is fine. So, just imagine if you got diagnosed with something like Miley-Cyrus syndrome or MCS, because all disorders have to have an acronym, and you didn't know anything about that. What kind of thoughts now are going through your head? Is this what you think, that your lips are going to be moving in weird ways? Is you're going to have this urge to twerk and stick your tongue out and all these type of things? And I immediately say, hey, don't panic, but by the time I say don't panic, you're already panicking. And then I say, hey, take these meds. These meds will help you with your Miley-Cyrus syndrome. You don't know what these meds are. You don't know how they're tied to Miley-Cyrus syndrome. You don't even know what the heck it is. And so it decreases the likelihood that you're going to take these meds. And then I kind of say, well, what would you like to know about it? We can't start out, we almost have to start out with the first question. Even when people have been diagnosed, being saying, what do you think that it means? What do you think it is? What is your belief? Plenty of people with schizophrenia say, yeah, the doctor told me I had schizophrenia, but I don't think I really have that. That's for kind of homeless people that talk on the streets. Maybe I have a mild form of it, but I don't have it. Okay, that gives me insight of how I'm going to then proceed with my psychoeducation. So you really do want to understand, especially when we talk about diagnosis and symptoms, the person's relationship to it and what they take out of it. I guess the main message to convey, which should be informed by the CFI, the cultural formulation interview, when it comes to psychoeducation, is one, that they're not alone. that, other people may have these experiences. And oftentimes, even people with fixed delusions will say other people have these things, but they don't talk about them. So it's that you are not alone, that you feel that somebody's out to hurt you. That can be really scary. I'm scared for you. So you're kind of creating this not alone process. You want to say that they're not necessarily responsible for developing the challenge, but there is something that you can do about it. Now, NAMI, the National Alliance for Mentally Ill, is really great at sending a psychoeducational message about psychosis, schizophrenia, bipolar disorder, those type of disorders being a neurochemical imbalance. Now, the purpose of them doing that, their intention was quite good. They wanted to normalize it. They wanted to provide psychoeducation that this is a medical condition like diabetes, like a broken leg, like a heart condition, that's something you can live with, but it's all medical and it's not your fault. That works for a good portion of people who have the belief of a westernized idea of medicine, that there are disorders that can be treated. And that can be a perfectly fine form of psychoeducation. However, it also can be quite stigmatizing. And some studies have shown that when we do an over-medicalized version of psychoeducation with clients, particularly clients who don't believe or share that belief, we actually increase anxiety, depression, and suicidality. Because, and which the author said in the study, is that when people heard that and then they went to the medication, and then the medication either didn't work or didn't work in the way that they had hoped, what message or what psychoeducation did we unintentionally send to them? We sent to them the message that they're broken, that they're made up of a bunch of neurochemicals, and how we treat these neurochemicals is through medication. The problem is when the medicine doesn't work or work in the way that they had hoped. So we want to send a message that, yeah, although they may not be responsible for the situation that they're in, there is something they can do about it, that they have control, that we're really trying to create an internal locus of control. We don't want people to be solely dependent on therapists, solely dependent on medicine, because if that doesn't work, we can actually then increase hopelessness. We want to really teach them that what they do and how they think about things have a big impact on their symptoms. That's the control piece. That you're going to make statements like you do understand their experiences, or you will do their best to understand their experiences. And what that does not mean is you don't have to collude with psychosis. If somebody believes that they're being, again, stalked by the government and there are white vans outside of their house, you don't have to say, yes, I see the white vans also, to build a relationship. In fact, do not do that. But what you can say is, although I haven't experienced that, if I did, I would be terrified. I had a client that believed that I was a shapeshifter, and I would go and I'd see him in his home because he didn't like to leave his home because so many people shapeshift, including me. I would go to his home and he would say, I don't want to let you in today. You were in my TV last night and you were this person on a show. And I would say I don't recall that, don't experience that, but I can understand how scary that would be. Could you tell me about that? Is there anything that I can do for you without coming in today? So really kind of giving a sense that I'm not alone, that I understand it, and that how he thinks about can have an impact. Say, what changed from last week where you let me in? What led you to let me in last week? Oh, well, it was fine last week. And I said, okay, what could make it fine today? Those type of statements. Again, I'm not colluding. I'm not saying that, yes, I was a shapeshifter, but I was, showing empathy in terms of how scary that would be. And then providing psychoeducation around stress, not, well, client, that you're experiencing psychosis right now, and I am not a shapeshifter, that's part of your neurochemical imbalance. That wouldn't have worked. We needed to focus on stress and how stress is really what was keeping that belief more prevalent. So we want to personally define recovery. Let me help me understand what's happening. Then let's help you better cope with the situation. Absolutely essential in work doing CBTp with, so in individuals with like psychosis. We do a technique in part of the psychoeducation phase that's called collaborative empiricism, which we're just asking them about the experiences. We're not, and what type of experience and what type of feelings they have based on those experiences, not providing direct medically based psychoeducation. So if they're talking about shape-shifting, asking, how does that happen? What's that like for you? Letting them explain explanations. We'll actually find, just by providing this Rogerian type of accurate empathy, that sometimes people start contradicting themselves and start wondering about their own thoughts without us ever challenging them, where we're just asking questions. And then what they do to cope, and that may be where the focus of treatment is. Okay, so when we do talk about normalizing, that's one of the goals of this phase. Again, what are we normalizing? So this is almost a summary. We're validating distress. We're validating the experience of the symptoms. We're validating and normalize reaction to the symptoms. We're normalizing guilt and any shame responses that they may have. I worked with a client last week who, while being psychotic, she harmed a family member. And so I'm validating and normalizing some of the guilt and shame that she feels about that. That would be, if I hurt a family member, that actually, I would feel that too. Even though, but saying, yeah, that she was overcome by psychosis. And I oftentimes use those words. I don't use the word you were psychotic. I say you were overcome by psychosis, because that's a way to externalize the symptom. I believe, again, it helps the client feel more control. I said, while that psychosis overcame you, you harmed somebody, I would feel terrible too. Have you been able to talk to your grandfather or your family member, kind of working on that piece. Methods to normalize, peer mentors can be helpful. Now, what we've learned about using peer supports with particularly younger people with psychosis is oftentimes younger people don't relate to the psychosis in the same way that the peer supports do. Where peer supports are most helpful is just of really normalizing shared experiences, not necessarily, and those shared experiences could be anything. They may not be the mental illness. They could be a shared experience and an interest in baseball. That actually can be quite helpful in using peer supports. You can use your own experiences, to normalize that, how you would feel, and especially when you start talking about anxiety and depression, those are things that are a little bit easier to normalize in psychosis. And then using data, some people like that, other people can care less, but it's just saying a lot of people, I might say that up to, if people have insight into their voices, I might say that there's data to suggest that up to 10% of people have experienced voices in their lifetime. That's a lot of people that have experienced that. This is actually a fairly normal experience in some ways. Now what we might then start getting into where it's starting to cause problems, and we can normalize how they feel about that. I really try to use this idea of the stress vulnerability competence model. I think I also gave you in your handouts, and I apologize, I don't have them in front of me, but I think I also gave you the stress bucket, which is another stress vulnerability competence-like model, which you can use with clients. I mean, a really strong psychoeducation, what we're talking about almost universally is the role of stress. That, whether they have anxiety, depression, psychosis, trauma, that stress mediates this. Lower stress symptoms are better. Higher stress symptoms are worse. So we take a look at their overall vulnerability. We do kind of talk about things that are probably not their fault. Their family history. If it's somebody that's heard talking about hearing voices and their parents heard voices, there's some vulnerability there. And then we talk about life stress as something that you can control. And life stress mediates protective and risk factors as the vulnerability. So when you have a certain amount of vulnerability, we might have to increase our protective factors and decrease our risk factors. And all of those together can create the risk of a reoccurrence of symptoms. So when you have a vulnerability, that's not your fault. and then we need to increase the protective factors, which might mean reducing life stressors. So we kind of talk this is a kind of a very normalizing form of psychoeducation. And it's very easy to apply to yourself. You can talk about your own vulnerabilities, and one vulnerability is high levels of anxiousness. That's why we give gifts. And so to reduce that anxiousness, that reduces your current vulnerability. So I will talk about, if I'm stressed, I'm more likely to get angry at my kids. If I'm running late, kid does something, I'm more likely to blow up at them. And so I can talk about it in that way. I've got more vulnerability at the moment because I'm running late, on my sympathetic nervous system is already activated. And give an example of what happened this morning, with my partner. My youngest daughter she's so creative. I'm reframing this. Creative, she's doing her exploration of the world, but she put a bunch of toothpaste in my partner's comb. My partner combed the toothpaste through their hair, and their stress level went through the roof, and was a lot more cussing and everything else. Where we had to decrease that vulnerability through breathing, and a future protective factor might be getting up a little bit earlier, those type of things. So I can use those examples. So that's a form of self-disclosure that can be really helpful in working with clients. Plus, it helps make you relational in that ways and kind of shift that power differential that does exist. Also, part of phase 2 is assessment. So it's kind of psychoeducation and assessment. So we're kind of going through the order here: engagement, gifts, psychoeducation. Then we move into assessment, which you've somewhat introduced when you were selling CBT early, which is the idea that this is a technique where we measure the outcome. That's inherent in the model. And we usually do this in, again, the macro part of CBT is structure, and we use structured assessments, not long, complicated ones, actually very simple ones that are meaningful to the client. And I'm a believer in Pearson's rule that that which is measured improves. So I'll say that to clients even, that I believe even by paying attention to the symptoms that you're bringing up, we can see improvement. And if we don't see improvement over time, this CBT practice isn't working, we can make shifts in the technique. Because my goal as part of being a CBT therapist is that you get better, and you get better, and you feel better. CBT, and I forgot to mention this, so I apologize, that CBT needs to be set up when you're doing that selling phase as a short-term intervention from 3 to 9 months. You're sending the message to the client that they're not going to be in this intervention forever. They might be part of the team treatment for a while longer, but for this intervention, it's short-term. And if it's not working, we need to change. But in order to know if it's working, we need to measure it. So it's just part of the treatment inherent. So what's the process of assessment? I mean, early on, it's a lot of, you can do Socratic questioning, which again, Socratic questioning is that collaborative empiricism piece where you're just asking questions about their experiences. And then we can use specific measures. So we can use something like those people familiar with Scott Miller's work, you're then familiar with the outcome rating scale. I am a huge fan of the outcome rating scale because the outcome rating scale measures, essentially the construct of the outcome rating scale is quality of life. It's not a symptom measure per se, although it does have some construct validity with depression, but overall, it's a quality of life measure. Because I've actually found in my work, I've actually seen clients not change in symptomology. So I'll do a symptom measure like a psychosis measure or something called the paranoid scale, particularly people with paranoia, I'll use that, and see that not change, but their outcome rating scale is getting better. So meaning that their quality of life is improving even though their symptoms are not, which is telling me and hopefully telling the client that although the symptoms aren't better, they're coping better. They're functioning better. their relationships are better, which is, again, really the goal of treatment. So I've also seen people's symptoms get better, but their quality of life isn't. So I really like to use at least two assessments when I do CBTp, a quality of life measure of some kind. I choose to use the outcome rating scale. There are other scales out there. There is one called the QOL, which is quality of life, and a symptom measure that's related to the client's specific symptom. So if they're talking about anxiety, I'll use the Beck Anxiety Inventory. If they're talking about depression, I'll use the Beck Depression Inventory. If they're talking about paranoia, I'll use the P scale. If they're talking about voices, there's the Distress of Voices scale. There is a scale for everything out there. These should be simple. It should be done on a regular basis. Each scales have different times in which they should be used. You would follow that. You track it with the client. And I actually use graphs and everything to kind of show progress, over time. Or if progress isn't working, I can go back and make changes. And I want to see how that's related to their goals, which is kind of their, probably goal related to symptoms, goals related to functioning, how it's all kind of tying together. And then I really start moving into a more advanced type of assessment, which is the case formulation. And we'll talk about what those look like in a second. So I use simple, brief assessments, and then I use a full kind of case formulation with the client in this phase of treatment. Now, what you're hearing is I haven't done really any interventions yet, other than maybe gifts to reduce stress. I've focused, and this could be, at this point, 6 weeks into treatment, and I haven't done intervention, what would be specific CBT interventions, focused on engagements, focused on psychoeducation, now moving into different forms of assessment. As we're kind of assessing beliefs, we're asking questions like, when did this first happen? Do you remember the first time you came to this conclusion that no one cares about you? You could replace that with a psychotic statement. Do you remember the first time you came to the belief that the mafia was there? Not telling them the mafia is a delusion. I'm exploring, this is a Socratic piece. This is a collaborative empiricism piece where we are being genuinely curious about people's experience. What other things you thought could be at that time, even if you no longer believe that now. Did you have any sensations in your body that supported what was going on for you? Asking those type of questions. So you can use the FIDO process when you talk about symptoms or experiences, whatever term they may use. How often does it happen? So FIDO's frequency, intensity, duration, onset. And then really overlaid by content. So how often do you experience this? From a diagnostic and treatment standpoint, we don't just want to understand whether or not somebody experiences voices. We want to know how often the voices happen, when the voices happen, and then the content of the voices. That all matters for treatment. There are some times when there's certain type of voices that respond to medications better than other types of voices. Sometimes voices are really related to trauma experiences. When someone is just hearing voices at night, that's different than people that hear voices throughout the day. So we do need to understand this kind of frequency and then the content. There's a different form of treatment for people's voices that kind of comment on what they're doing versus voices that say, you're a piece of crap and you should kill yourself. Those have different meanings and different forms of treatment approaches. We do want, again, as we do this FIDO approach, it has to be overlaid by content. So intensity, how bad is it? Duration, how long does it last? Whether it's depression, voices, beliefs, how long do you hear it? And then onset, when did it start? From a diagnostic standpoint, and whether you're going to do CBTp or CBTt, so cognitive behavioral therapy for trauma, and even when someone talks about voices, generally people that talk about hearing voices or seeing things in early childhood is almost always a trauma experience and not schizophrenia, not a psychotic experience. Different psychoeducation now, right? Different assessments you might use, and then ultimately different interventions. So this is all really important as you're doing that assessment phase. I'll go through these and then we'll take a break. Yeah, there's just different types of measures, and these are just some examples of measures, and I have all of these, and I'm happy to send you assessments. I just didn't want to completely overwhelm you with a bunch of assessments because they may not even be relevant to you. But here's some of the voices that I use specifically with CBTp, and they can be used for others, of course. I mean, these are not necessarily exclusive to cognitive behavioral therapy with psychosis. So in fact, like the PCL, which is the post-traumatic stress disorder checklist, so that's trauma-related symptoms. You know, when do you do it? You do it when you're first early on in treatment, and then every 6 weeks. It can take 5 to 10 minutes. The outcome rating scale and the session rating scale, which I do, that's done every session. It takes 2 minutes to get done. It measures overall quality of life, functioning, and therapy satisfaction. Other symptom measures, the BAVQR is a voices inventory. So if a client hears voices and talks about distressing voices, that's an important scale to use. The P scale is the paranoid scale. It really measures paranoia, but what I like about it, it can be used for people who don't have good insight because it doesn't use the term psychosis or paranoia. It says things like how often I'm distressed by people trying to harm me, or I believe that people are still trying to harm me. I believe that people are out to get me. So it talks about the experiences in a more normal, non-medicalized way. So I really like that scale. It can also just give me specifics around the type of paranoia they're experiencing, which then informs my later measures. And then there's depression and anxiety screeners. And so if people do complain about depression and anxiety, you can do that as well. And it's okay to do multiple measures. I mean, if you have somebody you're doing CBTp with because of psychotic symptoms, a good percentage of individual psychosis also have some form of depression and anxiety. And there's really good evidence to state if you treat the comorbid symptoms, so whether those be depression or anxiety, you can actually then improve the voices. It goes back to that stress vulnerability model. If we can reduce anxiety, we might actually reduce the voices as well. So you can use multiple measures. The key is keep it simple, very short measures that are actually used. There's a myth out there when it comes to measures that clients don't like measures. That has not been found in the literature. Clients are fine to use measures. What clients don't like is when measures are used without explanation, or the measures are used once and then filed and never brought up again. That's when clients don't like measures. So it's not the measures themselves that clients don't appreciate, it's how we as clinicians use them. If we use them like this, where we're making them part of treatment, where we're making it part of their goal, and we're using them on a regular basis, clients find them useful. If we just give them a Beck depression inventory or a PHQ-9 because we have to, and then put it in the file and never talk about it again, that's when clients get frustrated. And clinicians do too, because they don't really know why they're doing it. It seems like a waste of time and another form of paperwork that isn't useful. So if I'm going to use assessments, it has to be useful. All right, just a final thought. We'll take a break. Again, we want to prepare people for change. It could take some time, talk about the assessment, address any hopelessness, and then try it out. I mean, part of CBT is a little bit of experiment. Does it work? And see if things aren't changing, we'll make some modifications. That was pretty simple. There, I'm actually on time. All right, let's take a, oops, sorry, didn't mean to do that. Yeah, let's go ahead and take a break. I believe we kind of worked 15 minutes into it. So it's, what is it, your time? Is it 11:03 your time?
Correct, yeah. So everyone coming back at 11:15, if that works.
Okay, sounds good. See you all in about 15 minutes.
Awesome. All right, y'all, welcome back. We're just going to wait a couple seconds and have Dr. Melton hop back on. Yeah, we'll get started here in a little bit. Thank you.
I guess that was my cue to hop back on. Right?
Yeah, welcome back.
All right. Yeah, I wanted to take a quick moment to answer just there's a couple quick questions I can answer in the chat that are easy to answer. So I'll just go ahead and do that since it is related to assessments. Yes, one question was, are all these assessments free to use? I only use free assessments. So I recommend, using assessments that are free. So the assessments that I provided as examples are free assessments to use that don't require advanced qualifications or anything like that. And most of them are the assessments that the clients fills out themselves. So yes, all free assessments. The only one exception is that the outcome rating scale and the session rating scale, although they are free, you do need to register to use them. So you can register to use them at the International Center for Clinical Excellence website. And you can download the assessments. You just basically register and say, I'm not going to modify them or train on them without appropriate training and those type of things. But they're free. You just need to register. And then the other question is, if early trauma goes unchecked, is it possible for that trauma to turn into a disorder like psychosis? It's a really interesting question. I did a webinar recently for SAMHSA where I went over different forms of psychosis in adolescence, and I talk about trauma, what I call trauma psychotic-like experiences, because it's not true psychosis. It's experiences that tend to be driven by trauma, like the content. Why the content in CBT is so important is that it means something. You want to know what these experiences mean to people. So oftentimes people that are traumatized will have visual hallucination or visual experiences. I don't want to call them hallucinations because they're not fully formed hallucinations, but they're visual experiences like shadows or bloody heads, really graphic like things. And when you explore that with the client, they'll often say that it comes up when they're scared, or these shadow figures that they see are kind of reminiscent in some way or remind them of their abuser. So those type of psychotic experiences, very much trauma, and there isn't evidence that those type of experiences transition to psychosis, to true psychosis like schizophrenia. The psychosis that we see in schizophrenia tends to be much more bizarre and what we call of an ego, like of an alien ego quality. It's just weird. It's not something that they would ever experience. Like FBI is after them, those type of things. It's not related to any previous experiences that the client can really hang their hat on. So yeah, it's kind of the quick answer to that. I believe you can probably search for my webinar on that if you want more information on what trauma psychotic-like experiences are and what schizophrenia is and what other psychotic experiences are. But I think that, again, that all matters, and it's really important when it comes to CBTp, because even if this is an affective psychosis, a psychosis that's part of a depressive disorder, we need to be really targeting the depression. If this psychosis is part of schizophrenia, then then we're really focusing on oftentimes the feeling associated with the psychosis. If these are psychotic-like experiences related to trauma, we're focusing on the trauma work, and we can use more insight-oriented techniques when it comes to addressing the psychotic experiences. So content matters. So why it's so important when you do that FIDO assessment, asking about the content. It's not just about hearing voices. It's never just about hearing voices. What is the content of the voices? Where do you think they're coming from? How do you explain them? What do they remind you of? Are just really important questions. Yes, so there's a question about, so if someone has a schizoaffective disorder and they don't want to admit it, or I would say that the condition is overcoming them to a point where they can't admit it. That's inherent in the disorders. They really lack the ability to determine what was real and what is not. So yeah, it's not a won't, it's a can't. yes, you can use CBT to help them process the stressors that they experience. So if somebody again has unusual beliefs, we can talk about the stressors. And we can look at alternative explanations for those. And alternative explanations are different than, challenging a delusion. We all can have, get to a point where we have alternative explanations, but not necessarily that the belief isn't true. So there's different techniques, different levels of techniques that you can use with somebody that has low insight or no insight, schizoaffective, schizophrenia, delusional disorder, those type of disorders. That's a really great question too. But yeah, you can use it for all those. Okay, just shrink this here. Give me 1 second. Okay. All right, so the other part of assessment is the case formulation. And that's building a shared understanding. So I'll go through some simple case formulations, and then I'll talk about an advanced case formulation. The simplest case formulation, so here's an example of what I might draw on the whiteboard as I'm introducing CBT, is this relationship between thoughts, feelings, and behaviors. One of my early techniques is helping client, is an exercise in which I help them distinguish between thoughts and feelings, because sometimes people will use the word feeling, and what they really mean is thought. Like, I feel that sometimes people are really out to hurt me. It's not a feeling, that's a thought. So I try to help them, then when it's a thought, we have a little bit more control over. We can cognitively change those. Feelings are more along the lines of emotions, like I'm scared, I'm panicked, those type of things. So thoughts relate to feelings in that way. So, and then they can relate to behaviors. You have a thought that people are trying to hurt me. The feeling is I'm scared, panicked. The behavior is I don't leave my house. We have so that's a basic simple formulation. You can put those in there. What are the per client's thoughts? What are the feelings that result from that? What are the possible behaviors? And then kind of demonstrate how they're multi-directional. Feelings can also then reinforce thoughts, and behaviors can reinforce feelings, and behaviors then can reinforce thoughts. So that's, you can plug all that in for the client in a very simple formulation. This really is kind of the Band-Aid CBT formulation. Just what are some basic thoughts, feelings, actions, or what we kind of call the cognitive triangle here, or the CBT triangle. You would introduce this by putting in some of your own thoughts, your own feelings, your own behaviors. So role modeling is essential in CBT, so the client kind of gets it. It also builds rapport because it shows that this is a normal experience that everybody has. Just we as therapists, we go through the same process. So we want to talk about that and explore that with the client as well. Another kind of building up more advanced type of formulations is kind of adding the idea now of an event and interpretations. So we can talk about specific events in the client's life that lead to specific interpretations of the event that then can result in emotions, behaviors, and beliefs. And there's arrows all over the place because there is no clear direction in which way this goes. That an event can occur, an interpretation occurs, and it might lead to a behavior, might lead to an emotion, might lead to a belief. And a belief is the same as a thought in this particular formulation. I think I have an example of this. Yeah, okay. So let's take the event, just one example. You'd fill this in with a client, but you wouldn't do it until you've done it with yourself first, to explain how this could happen with you. But let's take this example where the client receives a letter from their primary care physician. The interpretation, of the letter is that there must be something wrong with me. The feeling or emotion is scared and anxious. The belief or thought is I am vulnerable to harm. And then the behavior is stays home and isolates. So you can talk about what you're really trying to demonstrate in an example like this from a formulation standpoint. It wasn't the event that caused this. It wasn't the getting the letter from the PCP that really caused the interpretation, the being scared, the thought that I'm vulnerable to harm or staying home and isolating. It was that whole process that did that. So if we can kind of change any one of these things, I mean, the good news, we tell clients, we can intervene anywhere. You know, where we can't intervene is we can't probably stop letters from your PCP from coming. But what we can do is we can intervene at the feeling level, we can intervene at the thought level, we can intervene at the behavior level, we can intervene at the interpretation level. And we can also continue to explore this a little bit further, particularly the level of interpretation. Has there been other events where you have that same interpretation? Because that may start to get at a real core belief that I'm unhealthy, or that there is always been something wrong with me. Then we can start this is kind of getting back to where CBT does start to address historical challenges, childhood challenges. Was there events in your childhood that resulted in this interpretation? So that starts to get at kind of core beliefs in case formulation. So core beliefs are a little bit different than automatic thoughts, but influence automatic thoughts. Core beliefs are long-standing beliefs, we might call them seminal beliefs, that then the client starts to filter all their interpretations and thoughts, behaviors, actions, those type of things through. So they could be something like, I'm worthless, which can have some childhood implications, can have a wild range of implications. So anytime an event happens, it's that core belief that the event's being filtered through that's then resulting in additional thoughts, feelings, and actions. So symptom content will start to make more sense when you understand core beliefs. So even going back to even paranoia, a lot of paranoia is based on a core belief. Usually it's the core belief of I'm not safe. So addressing the core belief can address a wide range of even symptoms. And again, symptoms are often a result of thinking errors specific to the individual's view of what we call the cognitive triad, different than the cognitive triangle or the CBT triangle, which is the individual's view of themselves, the world or others, and their future. So depression sometimes is often due to a view of one's self. Anxiety often is due to thinking error related to one's future. Paranoia sometimes is a thinking error specific to how individuals view the world and view others. This is, we want to start getting to these core beliefs, and we get to core beliefs through case formulation. So let's get just really specific, start talking about different forms of psychotic experiences that people have and why that matters, why content matters, and how that the clinical subgroup of psychosis may even speak to an individual's core belief. So we'll start with sensitivity psychosis. Sensitivity psychosis is, and this is language used by Kingdon and Turkington. They wrote kind of a seminal book on cognitive behavioral therapy for psychosis, or sorry, for schizophrenia is the title of the book. Really great book if you really want to get into this more. So definitely encourage CBT for schizophrenia, Kingdon and Turkington. I think it's been republished now. I have the 2005 book, but they recently republished it. So when they describe sensitivity psychosis, I think they're really kind of talking about what we think of when we think of schizophrenia, and Kingdon and Turkington's out of the UK. So maybe there's some cultural differences there, but the onset's in the teen and early 20s, and then we do see stressors precipitate easy first episodes or makes psychosis worse. Sensitivity psychosis are probably true psychosis The primary delusions are delusions of reference, thought broadcasting are common, especially when overstimulated. Also have negative symptoms and highly involved caregivers. So understanding that, it gives us a sense of, what some core beliefs are, especially when we start getting into thought broadcasting. People can read my mind, I'm not safe. There's a lot of those experiences in this kind of sensitivity psychosis group. We also have caregivers that also start to develop thinking errors, like my son or my child is sick, so therefore I have to overcare, which then creates this stimulated environment, which makes symptoms worse. So again, that's why a lot of work, I'm even doing thinking errors and predictions with family members who are making statements like, the core belief is I need to care for my child. They are not safe in this world because of what they're experiencing. And then the behaviors are, I need to kind of walk behind them every step. Unfortunately, that then results in the client feeling more anxious and increasing the psychosis. So different approaches based on the type of psychosis. Look at drug-related psychosis. That's psychosis that are influenced or started by drugs, tend to have more of visual hallucinations, and if they do have audio hallucinations or auditory, hallucinations, it tends to be around the theme of people are trying to hurt you, really paranoid themes. Onsets are still in teens and early 20s. And they tend to be more rebellious, and they tend to have poor engagement in the mental health system. So with drugs, we may focus on the drug use CBT around drug use. We might be doing a lot of work around the paranoia. We do a lot of work with the stress vulnerability model, that because of their vulnerability, the substance that they use is an external stressor making the symptoms worse. The good news with drug-related psychosis is oftentimes these individuals have insight into their psychosis, different than what we see in sensitivity psychosis. So we can sometimes talk about the relationship between the substance and the symptoms, because they're able to do that in a lot of cases, certainly not all. And then we can address the paranoia from that stress vulnerability approach. So I just did an agreement with a client where we were going to test this out. He agreed to cut down on his marijuana for the next 30 days just to see, and then we were going to monitor his paranoia, see if it gets better. We're testing a hypothesis. I wasn't saying that the marijuana was good or bad for him. What I was saying is that there seems to be a relationship between your use of marijuana and these paranoid beliefs. Let's see if that's true or not. And we'll find out. If you're willing to, cut down or stop for 30 days, we'll do these scales and see if things get better. Now, talking about this trauma psychosis, these type of experiences are more abusive. The auditory hallucinations tend to be abusive, violent, of sexual content. They tend to speak to the person in a second person, like you're enter swear word there. You should kill yourself. They tend to be shocking and of some alien quality. We call them ego dystonic, experiences. They're distressing. Insight can go in and out. They tend to blame themselves. We do see this associated with depression, post-traumatic stress disorder, and in older groups, borderline personality disorder. So again, different treatment approaches here and different core beliefs. Core beliefs maybe that I'm a terrible person. I'm at fault. I didn't do enough. Those type of beliefs. And then anxiety, psychosis tends to be much more stress related. Anxiety is relieved by making meaningful explanations for the distressing feelings, like, oh, the neighbors are responsible for, putting the chips into the walls and they're recording me. Isolation is common, and it usually starts with a strong belief that then develops into a delusional system. So that example I just gave, where it was with a client that did believe that the neighbors had planted recording devices, in their house, started with a fight with the neighbors over a dog or something. The dog got out, went to the bathroom in the yard. Neighbors got mad, said, I'm watching your dog, I'll keep an eye on it. We've got cameras up, and they really did have cameras up. And then that stress went from this true event of the cameras filming the dogs to now there's cameras implanted into my home. And it'll be a little bit later in life. And so then we can really start challenging doing clinical what we call behavioral experiments to see if the cameras are there, and those type of things, which we probably couldn't do in sensitivity psychosis. So this is a quick summary, but I hope it's starting to bring home to you why assessment is really important. Our formulation, is really important to understand the content related to the psychotic experiences that then will inform the type of CBT approach you use. And then here's just again a summary of that view of self, view of others, view of the future based on the type of delusion. So paranoid delusions, the view of the future is hopelessness. The view of self is I'm vulnerable. The jealous delusion, the view of self is I'm unworthy. The control delusions, I'm weak. Somatic, I'm vulnerable. Guilt, I loathe myself. Grandiose, I'm special and important, which usually means overall the feelings of inadequacy. And magical thinking, capable, possess powers and abilities, usually also has the underlying core belief of inadequacy. So how do we get to them? How do we get to these core beliefs? What's the other ways to do that? And there's different ways. There's the educated guess based on Beck's cognitive triad cheat sheet, which I provided to you. You can get through it through Socratic questioning. Again, Socratic questioning is that curiosity questioning. You can get to it by identifying a pattern of automatic thoughts. So if you start to see automatic thoughts around certain situations, such as situations around where they felt blamed, so it might mean that they feel guilty. If you start seeing those patterns, those are all ways to do it. You can use the downward arrow technique. It's one of Beck's techniques to really get at the personal underlying meaning of automatic thoughts. So if we think of the client, the automatic thought is, no one will talk to me if I go to this work event. Therapist asks, what would it mean if no one were to talk to you at the event? Client says, well, it means no one likes me. And then therapist says, well, what would it mean if no one liked you? That I'm unlovable. So that got at the core belief just using the downward arrow technique. I know I simplified it. There may be more questions than that, but I hope you kind of get the sense. It's a combination of focusing on the automatic thoughts and a Socratic approach. We look at a psychotic process. Client says, nobody realizes that I'm Jesus. Therapist, what would it mean if other people did see you as Jesus? And what you're seeing in this response is not something that's, we're not completely colluding with it, saying, oh, yes, you are Jesus. We're asking questions about it. Client says, well, that people would know that I'm the Lord and Savior. And then therapist can say, then what would being the Lord and Savior say about you? That I'm really important, that people need me. So then you start to get at the core belief that either it's one of that I need to be important, which oftentimes is a feeling of inadequacy. It's been basically over elaborated. I also really like to use this formulation. It's called the making sense formulation, in which we take a core kind of feeling, which might be depression, might be a trauma reaction, might be certain beliefs, and then we try to make sense of that. And we look at predisposing factors, so vulnerabilities, and these are the things that really aren't the client's fault. Parents having a history of substance use, parents abusing, or loved ones abusing, parents have a genetic history of depression, anxiety, psychosis. Precipitating factors, stressors that just happened prior to the onset of whatever the feeling is. So could also be abuse, could be substance use, could be a breakup. Perpetuating factors, stressors that maintain the symptoms. Negative thoughts about me finding another partner, ongoing voices. And then we also look at protective factors. We kind of call these the 4 Ps: predisposing, precipitating, perpetuating, and protective. So what are those factors that really keep people, or that could be helpful to people? It's also considered kind of a strength-based approach. We look at current concerns, what are kind of the outcomes of this belief, and then we do your simple CBT triangle of thoughts, feelings, and actions. We also may look at some social supports, social challenges, I put that under social, and then any physical challenges that are coming up, any feelings that are happening as a result of the challenge, and then any underlying concerns, which is really we start to develop once we have all the above completed, because our underlying concerns really are our core beliefs, that tends to perpetuate itself through a wide range of experiences. So this is, again, a formulation that I like to do as part of CBT practice. It's on the agenda. We're going to do the making sense formulation today, and we start working our way through it. Generally, I do this in session with the client. Yeah, those are your automatic thoughts. These are your core beliefs. Here's just an example, and I may have given you this example in your handouts. I also gave you a cheat sheet from the University of Washington. It really talks about the differences between predisposing, precipitating, perpetuating, and protective factors. Now, I don't get overly caught up. My students do this all the time. Tell them not to get caught up on this, but they get caught up on it because they tend to have a core belief of perfectionism and wanting to please the professor. But sometimes they're like, oh no, is that a precipitating factor or a perpetuating factor? I don't really know. And I'll just tell them, if the client sees it as one or the other, just go with the client. It's okay. Don't overly think about the differences. The easier ones are predisposing and protective factors. So you can kind of see here in this example, some predisposing factors are, biological vulnerability, precipitating factors, death of father, perpetuating factors. Didn't really talk about my symptoms, isolated myself. Protective factors. The client's motivated. If the client can't name one, usually I'll write, you came in today. You're willing to at least take a shot at getting this done. You made it today. And by this point, you would have already done engagement. You would have done assessment. So you can say, we've made it this far. That tells me something about you. It means you're willing to try difficult things. So you can usually always fill in a protective factor if the client struggles with it, which sometimes clients do. You write their concerns out. Really, these are kind of their goals or things they want to change. Like, I don't want to go back to the hospital. I want to have friends. You can do your thoughts. One thing I forgot to mention, when you do feelings, usually you rank how high these feelings are, on a 0 to 100 scale, 0 being not at all, 100 being extreme. So feelings of hopelessness, you can see it's at 70%, depressed is at 85%, worried at 90, and guilt 100. And then the actions as a result of these feelings or these thoughts, and keep to myself, stay in bed, pick on my skin, I think about cutting. And I got some examples of physical and social. And through all this, we were able to kind of come up with these underlying concerns that I can't trust anybody, the world is scary and dangerous, not as good as other people, or I'm defective. So quick and dirty, but this is partly why we do ongoing consultations. One of the case presentations, I ask CBT therapists to bring in their making sense formulation. We kind of talk about it. We try to come up with the core beliefs, and then it starts to also give us a sense of where we can start treatment. Do we want to look at thoughts, feelings, actions? Do we want to look at these protective factors and really try to strengthen them more? Do we want to look at trying to prevent precipitating factors? Just gives us a lot more information in terms of where to start the treatment. Okay, yeah, so I was starting to talk about that already, but how do we then translate the case formulation into these treatment targets or treatment goals? Once you review the making sense formulation with the client, let's identify What are the most important treatment targets? What does the client think are the most? That's going to be your best predictive. If they don't know, ask. Say, well, maybe we should think about buffering up some of these protective factors, and really strengthening that stress vulnerability model. And, then you kind of read the room a little bit. Client kind of goes, I don't know. So it sounds like that's not something you really want to work on, and again, you can always rank 0 to 100, how much if this is your top goal or not. You do different things to try to really get at the goals. And that's that collaborative piece. You work on developing a realistic problem and goal list, and then work towards translating problems into translatable, attainable treatment goals. Probably many of you are familiar with the SMART goal concept. That's specific, measurable, achievable, realistic, and time limited. But it is those type of goals. We don't want to create goals that aren't really attainable. And many clients say, well, I want to get a job as a police officer, but they're in high school and have a felony record already. And that's not going to be attainable. But I can ask, what is it like to be a police officer? What would it mean to you to be a police officer? Really start getting at those feelings, and then we can look at other approaches or other things to study to kind of hit a similar goal without hitting a goal that's not attainable. Why are goals important? Because one, they can create activation if they're personally meaningful. I think sometimes we can overvalue symptomology, because that's kind of what the medical model has taught us to do. Like, oh, if they're depressed, let's just reduce their depression. That may or may not be a motivation for clients. Or even if we do reduce their motivation, they still may not have the job or getting the grades that they want. I'm really a big fan towards meaningful, functional goals. In fact, I oftentimes will ask, even with clients who say, I feel really anxious and one of my goals is to reduce my anxiety, I might say, what are you going to be doing differently if you don't have anxiety anymore? Almost a reverse rehabilitation process to treatment. So if they can tell me, well, if I'm not anxious, I'm going out with my friends more, or I'm staying in class longer. I was like, okay, those sound like really good goals, because even if I don't reduce your anxiety, I might still be able to help you stay in class longer and improve your grades, which might mean you don't have the anxiety anymore, or it doesn't bother you as much. So almost kind of that whole Stephen Covey starting with the end in mind, really what it means or what they're going to be doing. I mean, is it enough for the client just to feel less anxious? For some, it may be. Others, well, no, I really do. If I'm not anxious, I'm going to be doing something different. So really getting that behavioral piece. You might then focus on skill building when you're doing that. Focusing less on the treatment of anxiety, focus more on skill building, which is that a lot of times people forget about the B in CBT, which is behavioral. You actually might do behavioral techniques. We're not even focused on cognition, we're not even focused on the thoughts. We're focused on doing something different, because doing something different can also influence the thoughts, which then may influence the level of anxiety if they've got a negative thought about their future. So you can go in a lot of different directions. Yeah, we can, making progress towards goals has a direct effect. So on symptoms, so they may notice when I'm busy, the voices go away, or an indirect. The voices call me worthless, but I helped clean the house this week, so still able to do something. And it's also a powerful goal. Having goals is a powerful form of relapse prevention. Changes that the negative beliefs of self, others, and future as part of the cognitive triad, and it establishes a life worth living, whether or not the symptoms are still present. All right, moving into the intervention phase. But again, before I do that, I want to do a check-in and see if any nuggets or takeaways from the assessment phase. What stood out to you? What will you remember? And what are you all taking away from that? I'm not seeing the chat now. Where did the chat go?
You said you're having troubles excuse me, finding the questions box.
Yeah, oh, there it is. I see it now.
Oh,
Got it.
sweet.
Okay. Mhm. Trying to get it bigger. No. There we go. I guess I am still having difficulty seeing.
It's all good. On
Yeah,
the top,
yeah,
sorry,
read
what
me.
was that?
Yes. Yeah, go ahead and read me a couple, yeah. And
Yeah,
having,
absolutely. So some that came through is 4 types of psychosis. It's all about collaboration, reinforcing the buy-in. It's crucial not to forget and also useful on an ongoing basis. Don't over pathologize. I believe the linear process with prompts and working with the client on percentages, etc., will be helpful with chronic symptoms. I like the fact that we can achieve emphasis on the achievements of personal goals instead of reduction of symptomology. And the last 2 are useful to address the basis feelings beyond the psychosis, and everyone is in their thoughts, not their feelings. And then we have, there are a lot of assessment tools to choose from.
there are, yes. You basically can come up with anything. Someone just wanted to had a client was working with a student, and a client was really wanting to focus on stress, and he's like, I don't know how to measure that. I said, again, there's stress inventories out there. The key when you use these assessments is that if you go through the questions, make sure the client agrees with them. I did have a client that said they were anxious and really did want to work on their anxiety, so I pulled out the Beck anxiety inventory, and we were kind of going through the questions, and they scored really low, even though they reported they were really anxious. Turns out they weren't anxious at all from at least a construct of anxiety. They were depressed. So they were kind of misusing the words between anxiety and depression. So yeah, it's important just to understand why sometimes even having those assessments can help you understand whether you two have a shared understanding between anxiety and what anxiety is. So I think that's another way that assessments are helpful. And there is one on just about everything, and a good portion of them are free and easy to use. Okay, great. Well, we're going to work our way through over the next hour, and I'll probably end about 15 minutes early, or not 15 minutes early, 15 minutes after, right at or give you 15 minutes at the start of the hour to ask questions. Go from there. All right, let's talk now interventions. Again, this intervention phase is a phase that a lot of people think CBT is, and they don't do the engagement phase. They don't do the psychoeducation phase. They don't do the assessment phase. They jump right to the intervention phase. And that's again, not full, that is what we call CBT informed, not cognitive behavioral therapy, not Fidelity-based cognitive behavioral therapy. Again, you can use them and you might get some help from them, but I wouldn't give up on CBT if you go right to the intervention phase and you don't find that that's helpful because you really didn't do the research-based Fidelity CBT. All right. So let's kind of talk about some of the things in your CBTp mailbox. And again, some of these are standard CBT techniques. Again, I mentioned this earlier that there are also behavioral techniques. People sometimes focus on the cognitive techniques. Again, with the primary or most popular technique that people are familiar with is cognitive restructuring. That comes from Ellis's REBT work. Again, it's a really great intervention. It's not something you want to jump right into though. There's kind of sub interventions you want to do first to really see if the client can really understand and see if if an REBT process would work. So I'll talk about some of those techniques as well. But I don't want us to forget about the behavioral piece, the skills piece of CBT, which might be behavioral activation and positive action scheduling. And I'll talk through some of these things as we move on. Developing coping skills, reducing safety behaviors. Safety behaviors are kind of escape behaviors. So if someone's anxious, they go to their their room. It also could be cutting is a safety behavior, makes them kind of feel when they can't feel, or a way to cope with anxiety. So we're really trying to help reduce some of these risky or potentially harmful safety behaviors. Reducing exposure to feared situations, thoughts, and feelings, and then behavioral rehearsals, which might be doing some practice, in the therapy with the client. We also can do behavioral experiments, which are both kind of a combination of behavioral technique and cognitive, because the idea is that you do something that then changes your thought. I mean, even asking somebody. So I have a client that asks his friends whether or not they heard what he heard, because sometimes he hears things that he aren't sure if they're real or not. And so he'll ask his friends. Now, these are friends that are super supportive. And one thing I've really learned to appreciate about adolescents is they don't seem to stigmatize mental illness in the same way that my generation did. I did a focus group with a bunch of adolescents at a few high schools and was asking them about what they would do if they thought their friends had a mental illness like schizophrenia, where they heard voices that other people didn't hear. And overall, the largest response was, I'd want to help them. Not that they're weird, I wouldn't want to hang out with them. I'd want them to help, that would be distressing. So it gives me a little bit more belief in our current generation, which I'm sure my parents' generation said about mine. So it's all cyclical in that sense. Other cognitive strategies, the payoff matrix, I believe I gave you a copy of that. Pie chart method we'll talk about, and then reality testing, which is a little bit of what I was describing as well. Okay, let's talk about just specifically CBTp techniques in terms of around conceptualization of hallucinations. Talked about this, but again, CBT is repetitious, but the content can clue us into the person's belief about themselves and the world. So again, just understanding the client hears voices or having a report that they hear voices is never enough when it comes to treatment. The content is key. Is this content about, are these command hallucinations to kill themselves? Or are these hallucinations that comment on what they're doing? Those type of different approaches to treatment, and it's also eliciting different feelings and potentially different core beliefs. The affectively laden hallucination that states you should die probably has a core belief of I'm worthless, the world is hopeless, the world would be better off without me. Those type of beliefs versus the voices that are commenting on someone's actions, probably resulting in core beliefs like I'm going mad or the world isn't safe. They also act as events, which can elicit automatic thoughts, beliefs, and assumptions. So the voice in and of itself can be an activating event, an event that then results in an automatic thought. Like, I'm crazy, I'm always going to be sick, then resulting in the feeling of depression, resulting in the behavior of giving up. So so even the voices themselves can be both a potential thought in some ways, but also can be the event that really kicks off the cognitive triangle or the CBT triangle. Cognitive model also states that our beliefs determine our feelings. So beliefs about an experience of voices can contribute to the distress associated with an auditory hallucination. So, I mean, if we can change how people believe about the auditory hallucination, then we change kind of the feeling about it. We change the distress level. So again, it's not always about getting rid of the symptoms. If we can conceptualize what the voices are doing that are potentially different, maybe this negativity is a warning that the voice is trying to tell you to stay safe. If they can think about it that way, it's not as distressing. So we can't always make the voices go away. Even clients that take medicines on a regular basis still will experience voices. So that's why I can't say the goal can't only or always be about reducing hallucinations. Again, what are hallucinations? At least from a cognitive standpoint, these are beliefs that maintain voices, increase associated distress. And then we can look at, again, look at the content of the voices. If these are power voices or omnipotent voices, you know, I have to do what they say. They can make bad things happen. You know, controllability, nothing I can do makes them better. Now you're starting to get at the core beliefs based on the voice. External, I hear them in the walls. Credibility, if they say they'll hurt me, they will hurt me. They say I'm worthless, therefore I am worthless. The voices are evil and they're trying to punish me. So the work of the therapy is to start to dismantle the beliefs associated with the voices. Now, hallucinations as a psychotic symptom tend to have much more insight, or the client tends to have much more insight in hallucinations than they do with delusions. So we can, with hallucinations, we can oftentimes start to dismantle the beliefs associated with the content of the hallucinations. But we first need to understand what the content is before we can start to dismantle that and to see what level of distress and what core belief is coming because of the content of the voices. This is a great video. I show it with, well, I think it's a great video. That's my complete biased opinion. It's a Stewart video. I have a link to it here. Again, I encourage you to watch it. It's almost like parts work in some ways, where you can work with the client to talk about the different, especially when they have multiple voices. You can also do this with clients with a bunch of negative thoughts that aren't necessarily hallucinations, but it kind of just speaks to that voices. It talks about how what we want to create with individuals is this whole genuine self. And in order to do that, these voices that exist are not necessarily external in a way, but they're parts of oneself that are just expressing those different parts. So the voice that says you're worthless, what there might be saying is, you know, if you try something new, it could be hard and you may feel like a failure. So it's really more about protecting you and thinking about it that way. If the voices are, the content is about fear, like you shouldn't go out, people are trying to hurt you, it could be that you're just trying to keep you safe, but safe in a way that maybe goes a little bit too far. So I will sometimes draw lines on my whiteboard on the content of the voices, going from anywhere from, you know, must do to not do at all, because I think there is some message in a voice that's saying that people are trying to hurt you. That sure, it's possible that there are people out there trying to hurt you, but do we have to listen to it 100%, or are there precautions that we can take? Because really what the voice is saying is not so much that people are all trying to hurt you, but the core meaning of that voice is that sometimes we need to be careful. What if we thought about it that way? And what if I put this on a different point on the line? It's not we have to listen to them, but that we can take their advice and then modify what we do based on their advice. You know, I sometimes tell clients when they say they feel like they have these voices of control and they feel they have to listen, we start to explore, well, what gives you that, you know, this is just another advice giver. Those voices are no different than me. I give you advice all the time. You don't listen to me. How do you do that? You know, so it's kind of putting it all on a spectrum in that way. So yeah, it's a really great video. I encourage you to watch it and share it with clients who have these type of voices. Behavioral activation. So this is where we're really focused on activity, having the client do something. That whole, you know, try something so you can endure it. Not so much fake it till you make it, but to kind of modify that to try until you can endure. Try until it becomes more doable. So it's the idea, and this is a really helpful activity for clients with negative symptoms, that amotivational syndrome, that asocial syndromes, where they aren't doing a whole lot. So it's trying to break that cycle between inactivity, low energy, low motivation. The idea that the more you do, the better you can feel. And then the less you do just starts to recreates that cycle, because now you have a behavior of isolating, which then creates the thoughts, I'll never be able to do this, which then creates the feelings of maybe depression, anxiety, sadness. So the behavior also, again, reminding clients that in the cognitive or the CBT triangle, behaviors, thoughts, and feelings are bidirectional. So you actually doing something can help you feel better. It can also inoculate a person from depressive symptoms, particularly or distressing symptoms. One thing we do understand about schizophrenia is that distraction techniques can be quite helpful. That when people that hear voices as part of a schizophrenia disorder tend to have less voices when they're talking to people, when they're doing something, almost distract themselves from the voices. So that this can actually be helpful. Then I haven't heard the voices as much. I'm less worried about the voices. I'm feeling more hopeful. So they can all kind of cycle together. This is why we sometimes see people with headphones, who are on the streets, who are kind of talking to themselves, or think those type of things, because the sound can actually help with the voices. I guess I felt the need to underline that, just so you really got the point. It's not as simple, though, as assigning activities. Again, that goes back to my comments on psychoeducation. It's very easy for us to hand a client an activity chart. Again, if you're not, you have to be deliberate. The activities need to be related to something that they're interested in. Saying going for a walk, or doing a walking group that that people don't have an interest in walking, although it could be helpful, they're not going to do it. We used to have a walking group back in the clinic that I worked in years ago, and rarely anybody showed up. And then one of us came up with a bright idea, sure it wasn't me, of asking the clients what activity that they would want to do, which was brilliant. And when we had them ranked, we had walking on there, almost none of them put go for a walk. Oh, that's why no one was showing up for a walking group. So we changed it into an ultimate frisbee group, and we also had kind of the I forget what it was called, but where you try to find things in the community, geocaching and those type of things. We did those type of groups, which had a lot more attendance. So those, they can. So it's not just assigning of activities. Oh, try going to the gym. Try talking to your mom. It has to be related to their goals and to their interests. Here's some examples. I mean, if walking is something they like, then we can do it together, and that's fine. Having the client teach you something. I really am a strong believer in increasing self-efficacy. So I love to hear client successes and then have them teach me how to do it. So I had a client show me how to play a couple chords on a guitar. I've had clients show me how to play video games, to really just kind of increase their sense of mastery. So they have successes, and if they can do that, they can do something else. And I'll sometimes ask them, as they're teaching me guitar, I ask, how much did your voices bother you just then? And usually it's not bothering them that much. It's just raising their awareness to that. Have them talk to you about a favorite topic, goal-directed, things that are really goal-directed. I used to carry like blank applications, or have blank applications in my office. Now you can do it online, but just complete an application, not for the sense of applying for a job, just to complete an application because you may want to use it in the future. And now you have it when you do want to fill out an application for a job. Doing something that's safe, that's just completely incompatible to their beliefs, like doing karaoke. Like, I can't sing, go do karaoke. You're expected to be a terrible singer. Thought diffusion, therapist invites client with a religious beliefs to give them a 10-minute scripture lecture. So this is the idea that I'm not capable. You have them do something they're quite capable of. And you can kind of talk about, one of your core beliefs, or one of your beliefs was that you're not capable of doing this. You were just able to give me this whole lecture, something you care about. What does that say about you that you were capable of doing that? And I say, well, it's something I know I'm comfortable with. Is it possible that you can become more comfortable with something new? How much do you believe you could do something different? But it's easier to ask that question when they've just done something that they feel competent in. When you do behavioral activation plans, it has to be very specific. You elicit a specific commitment. On Tuesday, I will. You know, it's not just, hey, go see if you can this week try to get out to a friend's house. That's not a behavioral activation plan. If it is going to a friend's house, it's, you know, on Tuesday, I will call my friend to see what would be a good day to come over, or for them to come over, or to talk over Zoom. A plan for remembering. With psychosis, memory, particularly short-term memory, is impaired. So, you know, are you going to text them with a reminder? Are you going to put a alarm on their phone? Are you going to work with a family member to remind them? Consider some CBT worksheet, you know, where they write down the activity and their reaction once they did the activity. You know, their belief about what was going to be like to do the activity, then what their belief was after they did the activity. And add more over time, bring in others to help. All right, so those are examples of behavioral activation. Now we'll move into behavioral rehearsal. And again, what I'm bringing up here is not necessarily in order. The techniques that you use in CBT are informed by your assessment and formulation. And everything's an experiment, you know, so that's why we're always rating before and after. Before we do this technique, how anxious you feel, how bad are your voices, how high is your self-efficacy, and then after you do it. And then we're always kind of rating, well, how did you were at a 50 and now you're at a 60. How did you move up those 10 points? Which I hope that gives you some insight on why I don't do 0 to 10 scales. I would do 0 to 100 scales, because there's more, although I know from a ratio standpoint, they're the same, but from a psychological standpoint, there's a lot of difference. There's 10 points in between each number on 0 to 100. There's only 1 point on 0 to 10. So so you can go from 70 to a 75, you know, and that's still 5 points better. You could ask, how did that work? What did you do? And certainly sometimes things go down and get worse. So you ask about that too. And then you thank them for sharing that things didn't work. And then facilitates a discussion on what you could do differently. So behavior rehearsal is practicing new responses to thoughts, you know, so compassion, you know, when the voice says, you know, you're going to be hurt, or some people are trying to hurt you, having a compassion for that voice, responding to the voice of, you must be scared. I can understand being scared based on experiences that we've had in the past. Thank you for warning me. I don't know if I need you today. You know, just really those new responses versus kind of the responses that are coming up. There's tolerating. We call this kind of voice time, you know, where you just let the voice talk. I'm going to let you say your piece, you know, and then you're done. Agree to disagree. That's not the way I see it. Just because you say it doesn't make it true. Positive coping statements. I know you're not real. I'm in control. This will pass. Doesn't kill me, make me stronger. Whatever statement that they can make in response to the voices. And you would practice this in therapy. You would rate it to see how much they believe it's helpful. And when they try it, was it helpful? So we're constantly kind of rating this. More behavioral rehearsals is creating a new narrative, which is kind of activating a stronger, more confident emotional part of the self that counters this weaker self. So we start thinking about the voices or beliefs or whatever as a kind of a weaker self that doesn't quite have the initiative that you have. So they make statements like, we always want to be scared. So yeah, it's kind of just creating a new negative of the hallucinatory experience, you know. And another technique is managing yourself as strong, powerful, and personifies the voice as a puny little laughable character. So, you know, I might even pop something like this up. I'm like, what if the voice was this? Again, we do start out with maybe drawing initially what they perceive the voice is, or I might have them go on the internet and we do an image search. And I say, find a representative of the voice, you know, and it might be this scary type of thing, or it might be a celebrity that's me, you know, things like that. I've seen lots of clients come up with lots of different things. And then I have some images that I have kind of readily available, and like, You know, what if this is the voice? How do we know that it's this big kind of scary character? What would it be like if this baby in the boots is your voice? Would you listen to it as much? You know, it kind of just adds that visual piece. Someone asked earlier about art therapy with psychosis. So this is a way if clients are really into art, instead of, I'm a terrible artist, so I use the internet more than I'm going to draw things out. But if you have clients that are, you yourself are an artist or the client's an artist, they can draw the images and then try to redraw it based on another image. And maybe even do this after you've done some cognitive restructuring or cognitive processes. And some more cognitive interventions. We just talked about some behavioral interventions. We'll talk about some cognitive interventions. Not all thought, I mean, one thing that we want to, the message here is that not all thoughts are created equally. You know, some thoughts are more or less accurate. You can give examples of this as you're kind of thinking about thoughts. I mean, have you ever asked them, have you ever thoughts that really weren't accurate? I know I've had thoughts that weren't accurate. Here's an example of me having a thought that was not accurate. You know, so it's creating the groundwork that thoughts are not created equal. If we can draw that, then we are more likely to be more successful when we do things like thought changing, cognitive restructuring. Sorry. Some thoughts are helpful, some thoughts are less helpful. But what we're going to be looking for here when it comes to thoughts are the thoughts that are both helpful and accurate. So you're really establishing that not all thoughts are accurate and not all thoughts are helpful. How do we get to a point where we're focusing on thoughts that are both accurate and helpful? Again, kind of a crux or key in CBT work. Some techniques to do this, it's got to be gradual. Again, we don't jump into, you know, one of the big errors that I see with people that are practicing CBT is they'll take somebody who has this terrible thought like, I should die, or I'm worthless, or the world will be better off without me, and jump right into attacking that thought. My advice is don't do that. You first have to almost do a scaffolding approach to build up that there are other explanations, or there are alternative explanations for thoughts. That not all thoughts are equal, not all thoughts are helpful, not all thoughts are accurate, and practice lower level thoughts before you jump right into the thought or voice or whatever that's really at the highest level. Use a SCID technique, you know, that subjective units of distress. Think about lower level thoughts that just cause a minimal amount of stress. Start there and work your way up. You're laying the groundwork, you're practicing, you're developing self-efficacy in your work before you really tackle these huge thoughts. Again, continued with the Socratic dialogue around the thoughts of the voices, very personalized questions. What did this mean? How long has it been there? What's it like for you? There's the alternative explanations exercise. I gave that to you. You can also do the pie chart exercise, which is you can use that whiteboard. Whiteboard's a really important tool. You draw a circle on your whiteboard and you start drawing out, you give your own explanations for a belief. And again, you usually start with your own. Like you might start with how you believe that your neighbor intentionally mowed your lawn improperly or whatever, something like that. Now, one piece of the pie is your neighbor's a big jerk and did it on purpose. Another piece of the pie is it was an accident. Another piece of the pie was he just wasn't, you know, he may have done it on purpose, but it doesn't really matter. Another piece of the pie is, well, at least my lawn got mowed, you know, and then we can kind of ask, how did you get that far in the pie? And that it could have been an accident. So it doesn't sound like it was all he was trying to hurt you or trying to be guilty about it, you know, or just, did something negative to you. So those are different ways to start to build up that there are alternative explanations. That is different from, especially when we start working with more fixed delusions, of challenging the delusion directly. We don't do that as part of CBT, but we do try to build the fact that there may be alternative explanations for beliefs, because not all beliefs are created equal. But again, we start low, go to high.
Hi, Dr. Melton.
Yes.
Had somebody ask if a flow chart would work here.
A flow chart. Yeah, I think a flow. I mean, if I'm thinking about it in the same way that the participant who asked that question, I think that absolutely could be helpful. You know, kind of build up to different thoughts, and then if this thought, then go to this thought. This thought might be this thought. Yeah, that could be helpful. If that was what they were asking, they can put in the chat whether or not that was what they were asking or not. I want to make sure I get that right.
Okay, yeah, thank you. It looks like you got it, so
Okay.
thanks so much.
Yeah, no, that's a great idea. I use that type of thing with the when clients are doing the I don't know, you know, the over, like you ask a question like I don't know. I take out my whiteboard, I draw a circle in the middle, I write I don't know in the middle of the circle, and I start drawing all these arms around the circle and give different explanations for the I don't knows. So I don't know, I don't trust you. I don't know, I don't want to talk about this right now. I don't know, this is private. I don't know, I really just don't want to be with you right now or be in counseling. I don't know, I have something better to do. I don't know, if I say I don't know enough, you'll leave me alone. And then I'll ask them, which percentage of these is correct when you say I don't know? You know, so it's, yeah, just different ways to kind of pull information from people. Yeah, addressing cognitive distortions, we'll talk about those in a second. And then using cognitive restructuring. You can't really do cognitive restructuring until you address cognitive distortions. And then reality testing and behavioral experiments. Although you're doing something behavioral, it also has that cognitive piece in terms of changing thinking. You know, and they don't always work. I mean, you have to be careful with reality testing. I'm not, it's definitely not something you jump right into. Because although at a logic level, from your perspective, you think it's going to work, when somebody's faced with data right in front of them that they may change their mind, I would say that didn't work with or people that were really anti-COVID injections or COVID vaccinations. There was good data for that. That didn't change people's mind. So again, sometimes even the most valid of data won't change people's minds. So like an example of this, which I've seen done multiple times, and of the maybe I've seen it done maybe 5 times, give or take, which never works, is when a client would have the delusion that they were pregnant, and they weren't pregnant. In reality, they weren't pregnant. So the reality testing technique was, well, let's give them a pregnancy test. Let's do an ultrasound. Let's do something that shows them there's no baby in there. And then usually what happens when they do that, they think the test is lying, or that you're part of a conspiracy to alter the ultrasound to show that they are really pregnant. It sometimes fails and turns them against them. So it turns them against you. I would say if you're going to do reality testing, it's people with kind of good level of insight, and you've done all of the phases. The other reason, and I'm not saying this might work, but every time I've seen that done, people were jumping right to it, saying I'll show them proof that they're not pregnant. Doesn't work. You've really got to build up to something like that and check a level of insight. I mean, I'm more likely to be talking to the client about what would it mean for you if in 9 months, I mean, people say this, what does that mean that you're not showing? What do you think about that? So really doing more Socratic type approaches before you jump right into, let's give them a pregnancy test. So those are some of those reality testing techniques, behavioral experience. Again, I wouldn't have a client ask their friends about voices unless they already had trusting friends, and the client would be willing to accept people that they trust, that there's an alternative explanation for what they're experiencing. But I've had to build up do alternative explanation exercises before I got to that. So just be cautious with reality testing, kind of my takeaway in there. So kind of moving into this whole idea of cognitive restructuring, we don't jump right into cognitive restructuring until we start with the ABC model for negative thoughts worksheet. And I've provided that to you. which is just a practice of what are possible explanations for negative thoughts. Or, somebody looks at you, what's a possible explanation for that? So again, you start benign, work your way up. So when you think about cognitive restructuring, and cognitive restructuring is really used for the most intense core beliefs, we start low and slow. So we do the negative thoughts worksheet first. So you're asking questions about, have your thoughts ever turned out to be untrue? What evidence and experiences point to the fact that this belief about the thought is not completely true all of the time? And I think that's a much nicer way to ask about thoughts versus saying, what is the belief about this thought is not true? Because then it makes this statement that thoughts are binary, either true or not true. And that's rarely the case. Thoughts oftentimes are on a spectrum, even for us, for people that don't have kind of negative beliefs or voices or delusions. There's never a truth and not truth. It's all on a spectrum. So I think it's helpful to ask, is it possible that, or there's ever been any experiences that you found the thought is not completely true all of the time? What does it say about the thought that there have been incidents where you got it wrong? Could it be possible the thought's fallible? I mean, you're going slow, building up. You're not immediately challenging negative thoughts. All right, I'm going to get into delusions a little bit more and some of the techniques specific around those. Kind of delusions, one, they're not always fixed. They're not always completely false beliefs. Again, that assumes some binary facts about delusions. Usually delusions are based in some form of reality, but the reality has been distorted. And that's why it's important to understand the content, when it started. Were there any events that led up to starting to feel this way? Not saying when you got delusional, but when you started to feel this way, when you started to believe that people were following you or notice that people were following you, what was going on in your life at that time? So really asking about those. And delusions also vary in terms of how upsetting they are. Some are really upsetting to clients. Some clients can ignore, and we may work on ignoring them. They vary in how much of time they think about them. And they vary in terms of the amount of efforts that people use to resist the thoughts. So this kind of gives us the opportunity to not always try to fix the delusion or make the delusion go away, but we might try to reduce how upsetting the delusions are. We might be able to reduce the amount of time that the person thinks about the delusions, and we might be able to reduce efforts or increase efforts to resist the thoughts or have more effective efforts to resist the thoughts, none of which is a goal of making the delusions go away. As again, in my experience, worked with schizophrenia for a long time, when people do have kind of delusions that are somewhat persistent, even with some of the medicines, they don't go away fully. So we do then have to focus more on, changing the level of distress that it causes individuals as opposed to making them go away. We do want to conceptualize the delusions. This can be done with a making sense formulation. It's possible to make sense of the beliefs when the context is understood. Some people do have, especially when it gets around to paranoia. Paranoia is interesting because it's oftentimes based in some reality that they were hurt, they were attacked, or they believe that they were. And that's just important to understand that. While delusions can be rigid, they can also be amenable to change if we can create the stance that beliefs can sometimes have different meaning. Sometimes there's alternative explanations, not all the time. Sometimes there's alternative explanations for things, for thoughts in general. Then we might be able to have modifications to the delusion. We also want to look at the function of the delusion. Is it about avoidance? Is it about protecting self-esteem? Is it to provide meaning and certainty about life? Really trying to understand what the delusion keeps them from doing, and what's the positive function of the delusion. From a behavioral standpoint, there is something that that having the delusion or acting on the delusion benefits. You know, keeps me safe. That's what I hear a lot. Keeps me safe. If I don't go anywhere, or if I lock my doors, I'm safe. And you say, okay, are there other ways we can keep you safe? Where then you can also go out and see friends or see family, or do something different, get a job, go to the park, go for a walk, whatever they want to do. What else can we do? And sometimes that does involve strategies that are still within the delusional realm, but it helps people feel safe. The client that believed their food was poisoning, I wasn't changing that belief. We got around it by preparing. She was in a group home, so we worked with the group home manager to allow her to prepare her own food or to watch it being prepared. And she felt better about eating it. She felt safer with the food. Didn't change the belief, but it caused her less distress if she was able to watch the food being cooked. You know, and just like any other thinking error, they're more likely to occur during some form of negative affect. And delusions get worse under stress, anxiety, anger, boredom, guilt, sadness. I mean, a lot of people have delusions because they're not doing anything else. They're getting caught up in their own beliefs. And if we can get, that's where behavioral activation can become really helpful. Doing something, maybe there's the content of the delusion is not bothersome. The client that we took fishing, that when he was fishing, it didn't really bother him, but when he was in his hotel, I would say his apartment, he was completely delusional. But if we were able to get him out and kind of change the subject when we talk about delusions, he's fishing, he wasn't thinking about it as much. We'd be able to ask him, what's going on there? You know, and it just, then that starts to build it up. All right, so some intervention strategies for paranoias and other forms of delusions. You can cause some reattribution through the making sense formulation, through normalizing, particularly in paranoia. Paranoia is, again, not always a bad thing. It keeps us safe, but we don't want it to paralyze us. So where do we kind of find that balance, that more normal, that it's normal to want to feel safe? I would always want you to feel safe. You're just going to an extreme to feel safe. Is there a way to kind of find a balance there where you can still feel safe? Because you don't want to have any lack of fear at all. If you don't have any fear, you may hurt yourself, or you might put yourself in a dangerous situation. So it's kind of just treating paranoia as a spectrum. So the alternative beliefs exercise, which you do have a copy of, you want to start with that before you do any type of changing cognitions, particularly around paranoias and other forms of delusions. Fairly self-explanatory. Cognitive restructuring is identifying and modification of kind of the delusions and beliefs. We can also use coping strategies, which I gave an example of someone that would want to watch their food being prepared. That was a coping strategy. It helped. They ate dinner and it didn't bother them as much. Or other behavioral experiments. And then replacing the functions of the delusions. That paranoia is about feeling safe. Are there other ways to feel safe? Or it's a warning and not a reality. Those type of approaches. So let's kind of talk through the alternative beliefs exercise. It does teach cognitive flexibility as a skill. And what that means is that there are alternative explanations, that none of us can be completely black and white in our thinking, that sometimes our thoughts are wrong or partially wrong. And again, you want to build that up. You don't want to jump into cognitive restructuring first. You want to do alternative beliefs. So this exercise begins with coaching around generating alternative beliefs for everyday scenarios. So normal scenarios, someone looks at you. Is it possible that they dislike you? Is it possible they just happen to look in your direction? If having a thought about you, how much does it matter? Then you progress to more scenarios that are tailored towards the individual's negative beliefs. So we start benign, start with everyday scenarios in which thoughts can occur that can be negative, and then we move to more tailored ones. It's all based on the cognitive model. So again, if somebody calls you on the phone and doesn't leave a message, if your belief is it's the mafia, you're going to feel anxious. If someone calls you on the phone and doesn't leave a message, it was a wrong number, you're going to feel more calm. Someone calls you on the phone and doesn't leave a message, it was a telemarketer, you might be slightly annoyed, but it's not going to cause you significant distress. So again, it's kind of, yeah, it's taking an event like somebody calling you on the phone, and what are possible beliefs for that? How much do they believe each one? And explaining how the consequence is different based on the belief. That the event itself, someone calling you on the phone, doesn't cause the consequence. The belief mediates the consequence. So we change the belief, we change the consequence. When you do this exercise, you're remaining neutral about the explanations. You're not saying yes or no. The goal is not to come up with a correct appraisal, but to acknowledge that most of the time we do not really know why something is happening in the way it does. It's really kind of building up a skill. You know, that's again, this isn't a find the evidence activity. This is acknowledging that we don't always know why things happen, to help the client loosen up their thinking rigidity and reduce this jumping to conclusion, reducing some of these thinking errors. So if you're looking at that handout, you start with responses filled in and move towards coaching of additional responses, and then to independent exercises. Some of the probe questions as you start to look for alternative explanations are, what's another possible explanation for the person looking at you and why this may have happened? What are other factors that may have contributed to this happening? And then use the pie chart exercises too, as you're kind of writing out all those explanations and how big it is in the pie. Just to acknowledge that there are alternative beliefs for things happening. You know, and they're not all equal. It's not an equal pie parts. Usually some are bigger than the others based on your experiences, core beliefs, everything like that. But again, the goal is you're just acknowledging that there are alternative beliefs to things. Right? So that's the alternative beliefs exercise. From there, once the client seems to be able to master that they at least acknowledge the possibility that there are alternative beliefs. Doesn't mean that they're completely out of their delusion. It's just that they can acknowledge that there are alternative beliefs for personalized situations. Maybe not the biggest situation, not that the FBI is implanting microchips into their brain, but maybe that's, that maybe they're not as followed, or that car that they saw was possible it wasn't the FBI. That it could have been just a car that was a white car that similar make and model to the FBI. That's a common car that people buy, or that you were feeling scared and you thought that at the time. That there are alternative explanations for it. Once they get there and they can really do the alternative thinking exercises, alternative beliefs exercises, then you move to cognitive restructuring. You need to stay in alternative beliefs for a while, stay in that exercise for a while. But the caution is don't move to full cognitive restructuring until alternative beliefs. You feel confident about that. All right. So what is cognitive restructuring? How is it different? It's the skill to help clients recognize and then potentially modify inaccurate, unhealthy, but understandable beliefs in order to reduce the stress, move towards goals, and move towards more healthy behaviors. So really getting at those thoughts that are really keeping them stuck. We're still going to continue to build off the skills we've been using in CBT all along: Socratic questioning to encourage flexibility, teaching of the ABC model, which you would have already taught probably early on, but revisiting it if necessary, using the unhelpful thinking styles worksheet. I've provided that to you. That's all the cognitive distortions. That's examples of black and white thinking, all or nothing thinking, predicting the future, those type of examples. I provided you a sheet with those. You want to make sure the clients understand those, that they can give examples of those in their own lives. And you, of course, will give examples of what's happened in your life. Having the client understand what good quality evidence is. I would say, do you think that would hold up in a court of law? What would you think about that? When Judge Judy was more popular, I'd say, what would Judge Judy say about that? You could ask, you can make those type of statements, but you're really overall looking at good quality evidence and teaching about good quality evidence. You've done the pie chart, you've done alternative possibilities. Now you're ready. Now you're ready to move to CR. And there are 5 primary steps to cognitive restructuring. Generally, this is used with adults, younger kids. I kind of call it, so like children to adolescents, early adolescence anyways. I use the catch it, check it, change it approach, which is basically a simplified version of cognitive restructuring. The catch it is catch the thought. The check it is check the evidence of the thought. And if the evidence outweighs the thought or support, then you change it. If the evidence supports the thought, then you can maintain it. But that's, so I kind of teach that, and there's another worksheet that's kind of catch it, check it, change it. So that's younger kids, just because I want to reduce the steps and make it a little more developmentally appropriate. But older adolescents, adults, all use the full cognitive restructuring process, a full 5 steps. Again, before you get into cognitive restructuring, they have to have a good understanding of cognitive distortions or unhelpful thinking styles, also sometimes called stinking thinking. Those thinking errors, there's all sorts of different terms for these. But we want to, give examples of this, and they're being able to identify examples of unhelpful thinking styles in their lives. They can identify dichotomous thinking, and that's seeing things in terms of 2 mutually exclusive categories, sometimes called black or white thinking. I can't trust anyone, where they would want to be able to say, well, I sometimes feel that way, but I understand that there's some people I can't trust some of the time. Other parts of the time, I can trust people. Those type of approaches. Labeling, overgeneralization, minimizing, should statements, personalization, blame, disqualifying the positive, positive experiences that conflict with the person's negative views are discounted. So overvaluing the negative. We all have these, we've all done these. So this is a great way to normalize when you get to this piece, because we're still going to be normalizing throughout kind of the whole process. And again, when I do this work with the clients, I pull out the unhelpful thinking styles handout, which I provided to you, and I give examples of of my examples of dichotomous thinking, my examples of labeling, my examples of overgeneralization, and then see what they could do. And again, it doesn't have to be about a full-blown negative delusion. You're scaffolding, you're building up. Again, and this is almost a measure of whether or not they're ready for cognitive restructuring, because they're going to at least have to understand in general these type of unhelpful thinking styles. So we want them to at least have mastery of this before we move on. Here's just more examples. And with psychosis, it tends to move more towards paranoia with these, which might be different for someone with depression or anxiety. Okay, 5 steps, 3 stages to cognitive restructuring. And remember, low and slow. Do not feel rushed. Do not feel like you have to get it all done in 1 session or 2 sessions. Go with the pace of the client. And again, make sure they're ready for it. So stage 1 is, which might be 2 to 4 sessions. You're introducing the ABC model or revisiting the ABC model. You're using non-activating examples, generic kind of therapist videos, doing the alternative beliefs exercise. You don't move on to stage 2 until the client has a good sense or has mastered the idea of the ABC link, that there's events that result in beliefs, and those beliefs have consequences, and they can go back and forth with each other. So the client's able to give examples of that. When they are, you can move on to stage 2. Stage 2, you introduce this idea of detective work, thinking styles. What is good quality evidence? Now we're really starting to use the clients as opposed to your own automatic thoughts that are not of high conviction. Again, focus on automatic thoughts, maybe around depression or anxiety, before you jump to automatic thoughts around delusions. So you're working on that. The goal in stage 2 is the client begins to internalize that thoughts are not always 100% true or 100% helpful, and that changing the way we think can lead to feeling better and acting in a more helpful way. When they're able to do that, you're done with you're ready to move on to stage 3. So stage 3 is really that intervention phase of cognitive restructuring. We know that the clients, how we kind of know that this is done is that the client starting to respond well to cognitive restructuring. The client can tolerate Socratic questioning and is starting to at least explore good quality evidence. The goal here is that you're really tackling the negative automatic thoughts, the NATs, and the hypothesized core beliefs is really what you're trying to do in this stage. Okay, so what does it all look like? Here's the worksheet or examples of the worksheet, and you have this. I provided this to you. You start with the situation. Ask yourself what happened that made me upset. Write down a brief description of that situation. What were the feeling? And then you can have them circle the strongest feeling. There's some examples there. They can also write in their own. And you're going to rate the intensity of each feeling. 0 being it's not there. Again, nothing's going to be a 0 because they wouldn't have circled it as a 0, up to 100. Then ask yourself, what am I thinking that is leading me to feel this way? Write down your thoughts below. And then you rank how believable the thought, how much they believe the thoughts on a 0 to 100. Then they will go back and revisit those thoughts and try to identify if any of those thoughts fit the definition of one of these or other all or not of unhelpful thinking styles. And they could have the sheet with them. Of course, they don't have these all memorized. I don't have them all memorized. But is it possible that can they go back and then identify that it fits one of these definitions of the unhelpful thinking style? Now they're going to ask themselves, what evidence do I have for this thoughts? Write down the answers that do support your thoughts and the answers that do not. A little bit of motivational interviewing strategy here. We always kind of start with the things that do support their thoughts. So we're not devaluing the evidence that they've held for a long time that really do support their thoughts. Saying that's still important. So let's talk about that before we even go into the evidence that might not support their thoughts. After that is done is the take action stage, which is ask yourself, do things mostly support my thoughts or do things mostly not support my thought? Check yes or no. No, the evidence does not support my thought. Come up with a new thought that is supported by the evidence. What's the new thought? They can take that new thought and then start out in the beginning and reapply everything again. It's a nice exercise to do if they're able to come up with a new thought. If they're not, the evidence does support their thought. Decide what to do next in order to deal with the situation, and we'll work on an action plan for dealing with the upsetting situation. So this is where if we can't get the client out of the thought, or in fact that the thought is reality, but it's still a distressing thought. Like, I've had clients that told me the thought was people don't like them, and all the evidence actually pointed to that people did not like them. What do we have to do then? It's not about changing the thought. Now it's about coping with it, or maybe we do some skills that understand how we can get, maybe add a couple of friends, something along those lines. Really focus on the more behavioral side of CBT. Again, I went through that very fast. This could be 5 sessions, could be 10 sessions. You know, you kind of work your way through it. Generally, it doesn't take me that long, but it could be 5 sessions. When we get to this idea of addressing evidence effectively, our role is to guide the process, not necessarily tell them what evidence is accurate or not when we're guided, help them generate evidence without us telling them what the evidence is. You know, we can gently challenge if the evidence for the belief seems unconvincing or not based in fact. But again, we wouldn't do this until we've done the alternative exercises and unhelpful thinking styles. We can point out that kind of sounds like overgeneralization. What do you think? You know, client really needs to learn how this process works. So we need to be actively involved initially, but the goal really is that they can start to do it on their own. And so we will gradually decrease our directiveness, our gradual challenging over time. Now, ultimately, a client can complete a full cognitive restructuring worksheet on their own. Things that we can do, we can provide hints of evidence to consider using Socratic questioning. We can help the client judge quality of evidence. Like sometimes I'll say, well, what would your friend say about that? Remind the client about what that criteria of good evidence is. Would it stand up in a court of law? You know, those type of statements. Prompt the client to use certain skills to develop and evaluate evidence. It's where have they done reality testing? Have they used the alternative exercise? Those type of things. Have they done behavioral experiments? And here's some examples of what that might sound like. You know, what would you tell a friend who had that same experience? What would you tell a friend who had that experience about how to think about this situation? What would a friend say or family? And I will, when I understand people's friends and families, I'm putting their names in there. What would Paul say to you about this thought? If that's their friend, I really try to personalize that. Were there any parts of the experience that were confusing to you or didn't seem to add up? Is there a piece of evidence based on fact or feelings? Would this evidence stand up in a court of law? Since this thought is an unhelpful style of thinking, what does that say about the accuracy of the belief? And how can you turn that into evidence? So asking questions along those lines. And I would hope you would kind of see that this is not something to take lightly, and this is not something to do right up front. You know, especially when we're dealing with individuals with psychosis and delusions, this has to be built up. This is never in session 1. Should never be an exercise that you're used to trying to use with the delusions early on. So those of you who are in crisis, please don't use this with the delusions right up front. You're going to focus more on engagement and gifts, maybe some psychoeducation. So really those first 2 phases of CBT are going to be more important for those in crisis, particularly with psychotic clients. With depression and anxiety, with depressed and anxious clients, you may be able to move into your cognitive triangles, and in that approach in crisis, that can be helpful. Those are more puppies, just because I've given you a lot of information and I went through it kind of quickly, and it's probably activated you a little bit, and you're having all sorts of questions like, could that work with this client? That'll never work with this client. Could work with that client. You know, so you're having all those thoughts. So again, I'm trying to reactivate our parasympathetic systems by having cute images throughout the course of my training. Let me see what we have here. Yeah, let's talk about negative symptoms. And then I think we'll probably be close to where we need to end, and I'll answer questions. So negative symptoms, just for a quick background, are symptoms that individuals with psychosis, true psychosis usually have, so like schizophrenia related psychosis. These are symptoms by definition that are when something is not present, they should be present, like motivation, like affective range, like feelings, like enjoying things that they normally enjoyed, it's just gone. We call them negative symptoms, not because they're bad symptoms, because you got to think about it as math, plus or minus, it's the absence of something. But these also sometimes can be confused with depression. These symptoms can be primary or secondary. primary negative symptoms are negative symptoms thought to be caused by the schizophrenia related disorder itself, or in the secondary negative symptoms are negative symptoms that are caused by antipsychotic medications. So we want to look at that too, because it's quite possible there's a biological influence or a chemical, influence on the negative symptoms, and might be talking to the prescriber about that. So yeah, what can happen with negative symptoms? You know, again, there's A is for absence. So avolition, amotivation. There's an absence of this. It's a limit in general activity, including personal care, going to school or work, low motivation to perform, which can then result in an underlying problem of defeated beliefs, high pressure, failure to meet expectations. And this can come from both therapists and parents. I've heard it many times, even from therapists, saying that client is not motivated. I sometimes think that's a thinking error, you know, from therapists, particularly with schizophrenia, because we haven't been helpful. So it's easier to, it's almost like our core belief is inadequacy, that we haven't been able to help the client, so we blame them. When really amotivation or avolition is a symptom of schizophrenia that needs treatment. And unfortunately, it's a hard symptom to treat. The medicines don't do a really good job with it. So before we call a client, particularly one with a schizophrenia-related disorder or a psychotic-related disorder, as not motivated, it might be that they can't, and it's not that they won't. We have to think about that. Asociality, not being very social, that's different than antisocial. Antisocial is criminal. Asocial doesn't want to be around people. Or there, actually, what asociality really is with schizophrenia is they don't believe that being around people will be of any benefit to them. They don't do it. So again, why the treatment could be skills training, helping them get to a social situation, being present in that social situation, or having a peer support or skills trainer or case manager present in those situations, and then rating, having that group kind of rate how they were feeling. Anhedonia, reduced interest in pleasure and activities. Alogia, affective flattening, and attention deficits. So I've got the definitions up here, but what's really probably more pertinent is the problem that these cause. And what ends up happening is the negative symptoms tend to also be then activating events for thoughts. You know, defeatists, I won't get along with anybody, that's hopeless. People won't understand me. I'll be demoralized, or I feel demoralized, or I'll be overstimulated. I can't pay attention. Why should I try? So we have those again. So we want to think about negative symptoms as a lot of times as activating events or an underlying thought, not a willful behavior. Yet they are challenging. They can be some that are resistant to change. Specifically, the medicines don't work as well. And yeah, as I was saying, because they're hard, we tend to, because we want to keep our own ego strength up, we tend to blame the client. We tend to say they're not motivated, and that's willful. I would challenge you that it's not. That's our own thinking errors. You'll feel like you're working harder than the client. You've all had that supervisor that's told us to not work harder than the client. I actively reject that feedback, particularly when it comes to schizophrenia, because sometimes, one, I don't actually know what that statement really means, and two, how do we know that our feelings are accurate when we're working harder than the client? And how do we know that, or how do we separate out accommodation and really kind of doing things for them, because again, if they have these strong negative symptoms, by working hard, isn't that not accommodating in the same way that we build ramps for people with wheelchairs? I've got to try to think about it that way, to change my own thoughts and working with really challenging symptoms. And in focus groups I've done with individuals with schizophrenia, they often describe negative symptoms as what's really getting in the way of the recovery. They might say, yeah, I hear voices and I can deal with those, but I can't think as well. And so they're making statements along those lines that really are getting in the way. And I've talked about that. yeah, so we're going to be treating the thoughts associated with negative symptoms, target these defeating beliefs. There's a getting motivated handout that I provided to you that can be helpful in working specifically with negative symptoms. And here's some of the interventions. So you'll have this of what you can do with each of the negative symptoms. And there we go. You will have to bring in for the relapse prevention side of the talk in the future. Oops. The wrong button again. Okay. I believe we're at that phase to answer questions, take comments, take any feedback that you all have on the presentation. I can start with questions. I'm going to try to figure out how to see those again.
Yes, thank you so much for that great presentation, Dr. Melton. I hope that you're able to see that questions box. Let's see, I wonder if it went back to your control panel and you just need to click that little arrow. Did that pop?
Yeah, I went back to my control panel. And so I got to click the arrow to
make it pop out.
Okay, that makes it pop out. And then the questions just seem kind of, they're all kind of smashed together, so I can't really read.
I can read them for you.
Okay, sure. Thank you. Sorry about that.
Yeah, it's all good. So the first comment / question we have here is, in your experience, what percentage of patients with schizophrenia related psychosis have better outcomes with medication? I've met a number of social workers who don't believe psych meds are useful at all. I agree 100% that medication needs to be optimally prescribed. Does medication improve capacity to engage in CBT for patients? Ooh, it moved for me.
There it goes. Sorry.
Does medication improve capacity to engage in CBT for patients with schizophrenia psychosis? So there's quite a few that were in there.
Okay. So I think the question, yeah, so I'll start with the first part of the question just around medications and schizophrenia. This is where assessment comes in helpful. I do believe, and there is ample evidence to support, that medications are effective with true schizophrenia. So schizophrenia that has delusions that kind of fit the characteristic of what, Kingdon and Turkington referred to as sensitivity psychosis. Medicines tend to work better with those forms of psychosis, and those forms of psychosis tend to be the schizophrenia related psychosis. People with more trauma related psychotic-like experiences, anxiety-related psychotic-like experiences, medicines don't seem to work as well. Because I think we're targeting a different, from a biological standpoint, I think we're targeting just a different system altogether when it comes to that. So yeah, that's when it doesn't work. Medicines for some people can keep the floor from falling out from under them, where it doesn't take the belief away, but it makes it a little more tolerable, or it's not as bad. I've heard that before with clients. All that being said, is all medicines, particularly antipsychotic medicines, have side effects. And those side effects, for some clients, the side effects are the cure is worse than the disease, and that they would rather not have those side effects and deal with their psychosis, or not recognize their psychosis. That's when it becomes really hard, when someone could benefit from medicines but won't take them because they don't believe that they have a psychosis. So that's a different approach altogether. That's when it can be hard also. But yeah, when medicines aren't working, that's when I go back, and it's a little bit outside of CBT, but I go back to the assessment. Was this a misdiagnosis? Particularly when we get at adolescents and younger people, just because schizophrenia is really rare before puberty, but people will get diagnosed with it prior to puberty, which is oftentimes not necessarily true sensitive based psychosis, and that's when the medicines don't work. So yeah, I think it can come down to diagnosis in a lot of ways.
Great, thank you. So the next thing that we have is, in your experience, what percentage of patients, oh, it looks like that got resent. Sorry.
Oh, no.
Let's see here. Lots of thank yous. And then we have, okay, in my practice, I would refer someone with these types of issues to others. Are there certain certifications I should look for in someone who is competent in this area?
Yeah, there are, you can be certified in CBTp. You know, I generally think, you know, I mean, there is a little bit of a stigma that we hold as even as therapists, or we don't feel as competent when we have psychotic symptoms, where again, I will say, you know, you met one person with psychotic symptoms, you met one person, give it a shot. I mean, what I really wanted to, even hopefully a message that I got through today was that we can normalize that some of that their content of whether it be delusions, hallucinations have meaning, which are oftentimes very compatible with the therapeutic approaches we use, whether it's CBTp, whether it's, you know, other forms of treatment. There's now publications that EMDR can be effective with this trauma-based psychosis. So you might be more qualified than you think based on what you already do. But again, if you want to get specific training, you can get certified in CBTp. I do this training over the course of 2 days, but it does involve a lot of role plays. Almost everything we talked about, we practice. We watch more videos, we watch more demonstrations. You know, I had 4 hours today, so I wasn't able to do all that. But that would be the kind of the next step if you really wanted to get more into this specific practice and feel more confident in working with individuals that have psychotic or psychotic-like experiences. But sometimes I think unless they're like acutely disorganized, I believe that therapy and almost all forms of therapy can be helpful.
Thanks. Next question is, what is your strategy when leading group therapy and a psychotic delusion is introduced by a group member which triggers others? How can we quickly address it for the group safety without jumping phases?
Yeah, it's one of those famous answers of it depends. Generally, when I did group therapy, there was a recognition that, you know, people had some of those challenges, so the group was pretty supportive of it. You know, just like any type of disruptive behavior, you know, if the delusion is disorganized or the person is interrupting, I focus on the interruption, not the content of the delusion, just like I would if any group member was interrupting or being disruptive. Certainly, if it reaches a threshold where it's causing so much difficulty or the person is in distress where they need help, why I really like to do groups with 2 people where I can ask one leader or myself, you know, take that person outside and we talk to them about it. You know, we've had this happen in non-psychotic groups where someone actively suicidal and was talking about it, you know, and the group was getting really distressed because they were worried about that person. And of course, I was worried about that person. We said, hey, let me just take a quick break. And I'd say, hey, Bill, let's go talk for a little bit. And then have my co-facilitator lead that. You know, another technique, and if the delusion isn't so pervasive that they're talking over everybody, I got very good at just normalizing the experience. So if somebody was talking about something that was way out there, I say, wow, sounds like that's really distressful, really focusing on the feeling. Something that may not be a good thing to talk about in this particular group because it was a different content, but let's touch base after group. All right, let's talk about this. Sounds like this is really, really bothersome for you to the point that you wanted to bring it up right now. And I hear that, I understand that. Let's touch base after group. If I can redirect it in that way, I certainly would try to do that as well.
Thank you. And we have 2 more questions. So the next one is, are you less at risk for a client with psychosis becoming dependent on you than other disorders? How do you maintain those boundaries if you continue to reach and they don't?
That's a good question. Yeah, I mean, I think because, and again, it's that whole depends thing. It does depend on the level of disability. Certainly, there are individuals with schizophrenia who are going to be in services for the majority, if not their entire lives. And I think when it comes to the idea of dependency, You know, that whole idea of enabling somebody versus accommodating. My general practice, this is me, and you don't have to agree, it's perfectly fine, is I'm going to lean towards that I'm accommodating as opposed to enabling early. And then I want to see if the client can engage in the skill. Can they do it? Not won't they do it, but can they do it? So if I'm driving them around or something, you know, can we get to a point where they can learn transportation on their own? But I'm going to do it early. If they're having, if it's about cognitive restructuring and I'm doing it all for them, can I get to the point where they can do it? So yeah, you're kind of testing it, because from a CBT standpoint, you're always doing teach backs. You're always looking what skills they are developing. Now, there certainly schizophrenia can be a very, very challenging disorder. I'm very much aware of that. That's why I try to do prevention work, where I try to catch it early, so we can do more changes versus someone with more chronic schizophrenia. I've worked with clients in the state hospital where they are going to need ongoing care. It really is. It's just going to be ongoing accommodation work. But I'm testing it. You know, I really believe in Patricia Deegan's statement of dignity to fail, where I'm willing to take risks with clients to see if they're able to do things, and giving them that dignity to try and see if they're not successful with it, because being not successful is an opportunity to learn. One, maybe they can't do it and they're going to always need an accommodation, or we need to change the strategy. So it's individual experiments with each client. Try to keep myself in check to make sure that it's not becoming complete dependency.
Okay, and I had another question come through. I'll do the quick one and then the other more complex one. So do you assign David Burns' Feeling Good book?
I have assigned activities out of the Feeling Good handbook, which is David Burns, one of the leaders in kind of cognitive behavioral therapy. There's some really great exercises. I like that book more for, you know, when I'm working with feelings around anxiety and depression. A lot of good strategies and activities within that book. I don't think I've ever assigned people to read the entire book. Now, some people have, because I've given strategies out of it and they went and got the book and did it themselves. But I oftentimes will copy some of the handouts or use similar handouts from that text.
Great. And I'll have this be, it officially is the last question, but in case any other future questions come in, we'll have to answer those via email so I can share a little bit more info about the CEUs.
Okay.
But this last question is, treatment team knows a trauma to be a delusion, but uncertainty about how to engage in cognitive practices without damage by potentially having her feeling without, I'm sorry, just a second.
That's right.
Treatment team knows a trauma to be a delusion, but uncertainty about how to engage in cognitive practices without damage by potentially having her feel rejection or dismissal of perceived trauma.
Okay. Yeah, we've certainly experienced those where somebody is feeling that they've been abused. I've heard that one, and there wasn't evidence of it. There was not in it, just the way it was described. It was truly a delusion was described. So again, I think that the key component there is you don't address the delusion directly. You start, again, that's why the phases of CBT are so important. That engagement phase, that really building that relationship with the client, having that in place. And then when you get to, you know, we don't have to focus so much on treating the delusion, but let's focus on treating the impact of delusion. What is the client not doing because of the delusion? Can we help there? Can that be a treatment goal? Or what is the client doing because of the delusion that's harmful that we need to stop or reduce? You know, where we all can agree is how distressful that would be to have a belief that you've been abused by somebody. And we got to remember, with truly kind of fixed delusions or persistent delusions, that belief is absolutely real, at least real to them. So we almost have to, so we can't challenge it in that way. We have to then focus on the feelings, how terrifying it would be, how scary it would be to have been abused. And then what are the consequences of those feelings that we need to start addressing at least early. Maybe we get this client up to cognitive restructuring, maybe we don't. but we can at least start moving through the phases and work and focus on really what we have control over. Sometimes we as clinicians want to fix the hardest things, the delusions, where it's like, let's just, maybe we take a focus on reverse rehabilitation and help the client with goals that they want to do that are maybe related or unrelated to the delusion. And that's where I would try to go with that.
Great. Well, thank you again so much, Dr. Melton, for this awesome presentation. For our attendees that are seeking that CEU certificate, please again refer to the reminder email and the confirmation email. All of the CEU information is there, and there are some requirements that you need to adhere by in order for you to be eligible for that. So that includes attending the entirety of the session and completing the evaluation. So please do complete that eval. You'll get a pop-up on your screen as soon as this training ends, and you will also receive the link a second time via email 24 hours after this presentation. So any questions, please do feel free to reach out to me, but otherwise, thank you again, Dr. Melton. This was a pleasure working with you and learning from you.
Yeah, I'll just say my email is on the full end of the full presentation, I believe. So people can reach out to me as well if they have further questions or want additional consultation or training. I'm available to do that.
Awesome. Thank you so much, everyone. I hope you have a great rest of your day.
Yep, you too. Bye-bye.
Thanks.